and I thought I'll just take this opportunity to invite you all to this meeting. This is a culmination of an initiative that started many months ago when we wanted to have I thought I'll just take this opportunity to invite you all to this meeting. Unfortunately, due to the this is a culmination of not possible. And there was a lot of culmination of an initiative that started many months ago when we wanted to have so that is how we started working on it, and finally we are having it here today. Ophthalmic trauma, we have a very eminent panel. Unfortunately, actually they do not require any interaction possible. Probably the person who needs to be introduced is myself. We convert a portion of this program into a webinar. In this whole panel. That is how we started working on it. Before I start, I would like to also welcome the president of the Kerala Society of Ophthalmic Surgeons. Actually, they do not require any interaction. Probably the person who needs to be introduced is myself. An Ophthalmic Society that is in this Gopal to this meeting. They are both here. Actually, the thought of this program came to me about 2 years ago when I was in Chennai for an ocular, and I had an opportunity to participate in that particular meeting. And when I was there, I was reminded of my very early days here in Cochin when I was working as a consultant in a multi-special big international meeting, and I had an opportunity to participate in that particular polytrauma. And when I was there, injuries at least 8 to 10 per month, and I was reminded of bilateral early days, series of bilateral here in Cochin when I was working as auto rickshaw driver, consultant in a multi-specialty hospital in 1990, a dedicated polytrauma unit. 4 cases. I used to operate a presented variety of open globe injuries, at least 8 to 10 per month, and I was reminded of a case of a bilateral series of bilateral corneal perforations in auto rickshaw drivers, which I operated between 1988 and 1990. Actually, I had 3 or 4 cases, which I presented way back in 1990 in an All India conference. So, and fortunately, those patients did reasonably well and they could continue their profession. And probably today we don't have such injuries because of the toughened glass that is used as a windshield. And probably that was not used in those days. So my interest in ocular trauma actually was very intense at that period of time. And I felt that this is one area which has got a very lackadaisical attitude as far as working is concerned as a subspecialty. And still, a lot of things have to be done. And I thought such initiatives will definitely help in improving the awareness about ocular injuries and what is possible, at least in some of these cases. So we have an eminent panel, and I would like to first introduce Professor Gobind Mukherjee, the senior most in this group. He is a well-known person. He is a former professor from the All India Institute of Medical Sciences, the RP Center. And some of my friends actually who were his students tell me that he was a great teacher. He is a very respected and renowned teacher. And he is presently the president of the Ocular Trauma Society of India and also the Eye Bank Association of India. Sir, very thanks for accepting our invitation and having come over here for participating in this particular program. Thank you once again. Dr. Natarajan needs no introduction. Actually, he is the president, and if I'm not mistaken, the founder president of the Asia Pacific Ophthalmic Trauma Society, APOTS. Nati is known to me ever since I became an ophthalmologist, and we are like brothers. So he is omnipresent. He is there everywhere. And I sometimes wonder how this corona has affected him, because he was a man who used to travel nearly every other day. And for a person who used to travel every other day to be stuck inside the 4 walls of the house for months together is indeed a challenging situation. He is a gifted surgeon. I mean, and his contribution in ocular trauma, I think, is in management of complex ocular injuries. I think he has shown a large number of videos in his younger days, and his very popular presentation is operating on eyes with no light perception. I've had an opportunity to listen to this talk also. So Nati, thank you for joining in. and I hope you will be able to give us a lot of information. Dr. Mehul Shah is from Dahod in Gujarat. If there is one person in India today who's really passionate about ocular trauma, I think it is Mehul and his team in Dahod. I mean, they are doing a high volume work in ocular injuries and ophthalmic injuries. And it is not a surprise that he is so interested. In fact, ever since the last 48 hours, Mehul has been very active in the WhatsApp groups, trying to promote this particular program. And thank you, Mehul, for accepting our invite. And I'm very happy you're here. And I understand that some of his colleagues are participating in the quiz program also. Rupesh is again a very old acquaintance. His interest in ocular trauma is since his Shankar Nethralaya days. If I'm not mistaken, he was in charge of the ocular trauma unit in Shankar Nethralaya for a couple of years. And today he is spearheading various initiatives in ophthalmic trauma, and of late the eye gates, about which there will be a talk sometime later during this program, is one such initiative which has been started by Rupesh. And I think the APOTS also is to a certain extent his initiative. Thank you, Rupesh, for joining in for this particular meeting. The other person I would like to introduce is Dr. Gangadhar Sundar. I don't know whether he has joined in. He had an emergency surgery in the morning, popularly known as Ganga. I've known Ganga for quite some time. And those of you who know Ganga, I mean, he's a very amicable person, very friendly person. He gets, he's so passionate about ophthalmic and ocular trauma that, he's having nearly 2 decades of experience. And this morning also, he has an emergency injury case, which he is operating at this moment of time.
He actually joined Giridhar.
Yes, just joined?
Yes.
Ganga, good morning and welcome to this meeting.
Good morning, Dr. Giridhar. Sorry I was late. Yeah.
It's okay. I mean, the only thing is we missed you during the pre-meeting introductions. So thanks for coming in, and we are looking forward to your participation. One of my very good friends is Dr. Guru Prasad. And if there is one person who is still continuing to do high volume work in ocular injuries, he is a versatile surgeon. He is a very well-known vitreoretinal surgeon in the Joshi Eye Institute in Hubli, North Karnataka. But more importantly, he is a versatile surgeon both in the anterior and posterior segment, and he is managing all types of complex ocular injuries in northern Karnataka. And I thought that his presence in the panel will be of great, it will really add some importance to the scientific deliberation. Thank you, Dr. Guru, for accepting our invite, and we are looking forward to your participation. So with the 2 keynote speakers will be introduced before the keynote talk. And before we start the sessions, I would like our Kerala Society President, Dr. Meena, to just say a few words so that we can give the program a start. Dr. Meena, can you just say a few words before we start the session? Thank you.
Respected dignitaries, the President of the Asia Pacific Ocular Trauma Society, Dr. Nadarajan, Dr. Govinda Mukherjee, the President of the Ocular Trauma Society of India, distinguished faculty, dear friends and colleagues, good morning. I bring greetings to all of you from the Kerala Society of Ophthalmic Surgeons, and I'm happy to participate in this session organized under the aegis of various eminent societies. Ocular trauma, we all know, is the most frequent cause of an emergency hospital visit and may vary in severity from a mild corneal aberration to complex ocular and orbital injuries. In this connection, I would like to highlight a few points: the importance of creating an awareness in the public and in the general ophthalmologists regarding the preventive aspects of household injuries, sports injuries, and workplace injuries. Secondly, that all of us should learn the ocular trauma score and speak in a common language. The general ophthalmologist should be aware of what they should do and not do. Trauma is a subspecialty which requires a lot of investment in terms of time, your surgical skill, and it earns very little in terms of financial aspects. However, this is a very, very interesting subspecialty and it requires global knowledge of ophthalmology transcending the boundaries of the anterior and posterior segment. This meeting, with its correct emphasis on educating the general ophthalmologists on the complex aspects of trauma, will be a great boon to them. I wish this meeting all success, good luck, and stay safe.
Thank you, Dr. Meena, for your lovely words. Now let us start our program. First, I invite Dr. Rupesh to introduce our first keynote speaker, Ms. Annette, to the audience. Dr. Rupesh, please.
Yeah. Thank you, Dr. Marian. And I would like to thank, first of all, Dr. Giridhar and Giridhar Eye Institute and the team for putting up such a wonderful show. And they've been after this for quite some time and they've really come up very well in the program. So thank you very much. On behalf of Asia Pacific Ophthalmic Trauma Society, it's really an honor to be here and representing APODS along with Dr. Ganga and Dr. Natarajan and all other APODS family members. And we hope we can contribute a little bit to the learning which Dr. Meena just spoke about. And Dr. Guru Prasad and all have been putting up a lot of efforts in that part of India. And hopefully this webinar can contribute in a way. With that note, I like to present to you one of the young, prolific person who is doing really some wonderful work on trauma is Annette Hoskin. Now, Annette Hoskin is not ophthalmologist. So this is something very interesting, which makes her profile even more stronger than some of our profile. But she has the experience and knowledge in the design and development of eye protection with in-depth understanding of the incidence and epidemiology of ophthalmic or ocular trauma to help develop effective injury prevention strategy, which has been lacking to a great extent, which I think all of you will agree. At the same time, she has published widely internationally in ocular trauma, and I'm really honored to be part of some of her publications. And she has published on the development of eye injury prevention strategies. Annette is currently the only person whom I know who's been doing PhD on ocular trauma in Australia. And she is a student at Safe Sight Institute under Professor Stephanie Watson and Professor Lisa Key. And she has been awarded the NHMRC Dora Lusk Biomedical Research Postgraduate Scholarship. She's also been appointed as a research fellow at the Lawrence Eye Institute, University of Western Australia in Perth. That is where she practices. Besides this, one thing which all of us will like to know is the main role. She's a global standardization manager for SLR. And SLR, you know, is a company who manufactures the glasses, the spectacles, and she's an Australian representative to International Standardization Organization Committee related to eye injury protection, sunglasses, and spectacle. So this makes Annette's profile really something wonderful for trauma, and she's really spearheading all the efforts for trauma ever since I met her first time in Singapore during our APODS meeting in November 2016. With that, friends, I present to you Annette Hoskin. Annette, over to you.
Welcome, Annette. I think we are proud of you, and I have actually settled into my optometry contracts that you are going to present. Welcome, Annette.
Wonderful. Thank you very much for the lovely introduction. I'm just going to share my screen. I'll go through my presentation. Just while I pull it up, I just wanted to say how honored I am to be presented. I really appreciate the opportunity to meet with you all today. Sorry, I'm just pulling up the presentation.
You have to go to share screen.
Yeah, no, that is working, but for some reason it's not giving me the option that I need.
Maybe you have to do escape so that you can see the presentation.
It's all right, I got it. I think I had too many screens open at once. Apologies. So I just wanted to share with you today just some little vignettes about the work that we've been doing, which Rupesh already mentioned, and many of you have already contributed to and participated in with us. So I'm really excited to be able to share with you some of that information and data. So with anything, I think it's always good to look at and think about what our starting point is. And really for what we're doing in ocular trauma or ophthalmic trauma, as Ganga very helpfully helps us to understand is that we're trying to pull together very different groups of people, and we're trying to provide strength and unity in that teamwork. So for us, there was a number of groups who've already looked at ocular trauma or ophthalmic trauma and pulled data, but in the past it's been very disparate with just a few individual countries providing data. So one of the key things we wanted to do, and I think the comment that was made by Meena about developing a common language, we all know about BETS and ocular trauma score, using this in a more cohesive way to collect data. But I also just want to talk you through about what we've done with iGates and the role that we think it's playing and can continue to play, and what we think the endpoint is, and how we're going to get there. So as I said, we already have this excellent tool developed by someone who's really well known to all of us, Ferenc Kuhn. So the ocular trauma score, as you all know, allows us to help prognosticate about the outcomes of ocular trauma, and that raw score and the points are gathered to give us a potential outcome. There are some limitations with that, and that's something we're looking at as well, in terms of more specifically for children. There's some limitations, and also thinking about the calculation of RAPD and other things. If there's hyphema, there's some other things that limit its application. But as I said already, there's a lot of data collected. I think we're starting to see more data coming through from countries like India and China. Traditionally, the US and other developed countries have had a lot of data, and a lot of the registries that were in place came from countries like the UK or the US in the past. So really, we're trying to help develop that common language so that we can understand the profile globally and look at what's happening. And I mean, you can see that there's huge variance depending on the country, and there's lots of factors that go into that, and lots of factors that go into when and where eye injuries happen, and what the outcomes are. But as with anything, the time that we spend collecting the data, we must be able to justify that by the value that's obtained. So one of the key things we wanted to do early in the process, that Rupesh mentioned, one of the papers we published was about eye injury registries, just to really understand what's been done in the past. And you can see from the profile of the different registries, there's a lot of focus on the US in particular, and we've seen a lot of data come from those countries, and a little bit more recently from registries in China. But certainly we don't necessarily get a good picture globally. So one of the things we're hoping to do is to be able to even the playing field so that we can actually understand in a more realistic way the injuries that are happening. So iGates is really a collaboration. There's a lot of groups, and some of them have already been mentioned today, but certainly the input that we've had from all of our collaborators, and in particular from these 4 groups, have really helped to push us forward in terms of the data that we've been collecting. And again, there's a lot of people on the call today who have been really instrumental in helping to support that. And that kind of collaboration, which started back not long after I first met Rupesh, going through and determining exactly what data we wanted to collect. So a lot of time spent developing a consensus around how we do that, and beyond that, developing the systems to be able to do that and making those available. And I mean, I know you all know Rupesh very well, but of course his reputation and his ability to bring groups together has just been fantastic over the time. And certainly this collaboration has been a really important one. This is very hard to see. It's such a large number of people, but I just do want to recognise everybody. And you can see there's lots of countries who've contributed already. and lots of individuals. And the time and energy spent collecting data is really important. And that data, one of our first publications, which is just in the submission process with ophthalmology, is looking at that global perspective and trying to get as much data as possible to try and understand more specifically about open globe injuries. And then we will move forward looking at the broader perspective. But this initial set of data, 785 open globe injuries, we had 7 countries and 12 centres participating. One of the key findings that we found was that female gender, older age and zone 3 injuries were some of the things that were contributing to a much higher risk of blindness. So I'm sure it's not unknown to you that we're seeing more injuries in older women in particular, and these are tending to result in more blind eyes. And obviously there's other complications with falls, but this in particular is a new finding that's not been established anywhere else. So the capacity to have such large numbers, but also over a diverse group, has been very helpful. So these are, looking at the data, you see all of this, the same sorts of things that you've probably seen before. One of the key things, again, though, is for us to have a really good understanding of when and where these injuries happen is the first step in us being able to prevent them. We need to understand this first so that we can develop prevention strategies. So the data that I shared was the general data that we've collected. We've also collected data relating to fireworks. And I know in India this is something that's very familiar to you all. And obviously they're starting to develop proposals around how to prevent. Well, this has been going on for some time, of course. And for those of you who were in Delhi at the meeting there was a proposal signed that was sent on to the government. I think we need to continue to put pressure on. I think for us in Australia, it's really interesting to see this because we're sitting on the other side of the fence. We can see the benefit of legislation, and for us, except the instance of the Northern Territory, which is one small part of Australia, they're allowed to, on a 24-hour period, use fireworks. But other than that, fireworks are very limited in use to just public displays. But we need to continue, even in Australia where we have such tough laws around fireworks, we need to continue to be vigilant, and there's still pushes to try and get rid of the use of fireworks even there. So this was the data we collected, and as you can see, we had a few centres and a few countries contributing to this data. This is currently under review with ACTA, so we hope this to be published soon. And again, trying to provide that more global perspective to understand exactly when these eye injuries are happening. And you can see in particular in terms of eye protection and supervision, really the rates are quite low, so that the role of education in particular is an important one in this category. And you can see as well, the other thing about fireworks is that you get a very poor visual outcome in a large proportion of the injuries as compared to other groups. So I'm just going to, in the interest of time, just flick through really quickly. I know that we're all quite aware of the statistics in terms of fireworks, but just to think a little bit more about how we can help to reduce the burden of fireworks and the eye injuries associated with them. And at the top of the tree is always elimination. If we can get rid of them entirely, would be the ultimate in terms of reducing eye injuries. But of course, if there's other substitutes, and I think in a country like India where culturally they're such an important part of festivals and that sort of thing. Maybe we should be looking at alternatives like the use of drones, really pushing for public displays rather than personal use if there's other things we can do that provide an alternative. And as we develop different administrative controls, I know in parts of India they have reduced the use of fireworks, and a lot of that comes down to air quality control. But if we can grab the benefit of that and work with these other groups, then I think we should take every benefit we can from these other interventions. So talking about our endpoint and where we're moving to, really we're trying to look at obviously the best endpoint for us is if we reduce eye injuries completely, and I know for all of us that would be a lovely outcome. As you would have seen with the case in Australia, as much as we can develop strategies and policies to reduce eye injuries, there's always potentially going to be some eye injuries, but if we can use that as our goal, and of course the improved management is an really important aspect as well. So I mentioned before about elimination, substitution, and as you go down that triangle, things become less and less effective. So it's really important where possible that we can eliminate the hazards. So all of those things play a role in terms of how we can reduce the eye injuries. There's lots of detail and lots of information about the role of things in terms of education policies and the use of eye protection. I think there was mention from Meena about sports, and there are a lot of high-risk sports either in the professional circles or the things that people do day to day. As people have more and more time for leisure, we're seeing sports eye injuries increase. I know that there was some data coming out of India in particular about the impact of COVID and the lockdowns. We can look toward all of these things to understand the profile of these sorts of injuries and how they might change. So moving forward, some of the other initiatives we're looking at, as I mentioned, the fireworks paper is about to be published. We're looking at data specifically around COVID and any change in eye injuries. In Australia, there was anecdotal evidence about people doing more DIY or do-it-yourself type activities around the home, and we've certainly seen more injuries there. We're also looking at ophthalmic trauma and doing a survey related to ophthalmic trauma terminology. So as I mentioned right at the beginning, BETS and the ocular trauma score have been in place for a very long time and are very effective and very, very helpful. But we're trying to really broaden that to include things around the eye as well, trying to make sure that we have a clear understanding of things like foreign bodies and classifications of those. So we're currently developing some more work in that area. And we're also looking at doing a prospective study using data from electronic medical records, but also an online way of calculating through diagrams the ocular trauma score and also the types of injuries. So there's always more to do. As Rupesh said at the beginning, my focus is really on the prevention side of things. The data we're collecting is a really important tool in us developing prevention strategies. I would invite you all to get involved if you're not already a member of APOTS to join. It's a really active, great society that helps to promote the need for reducing ocular trauma, but also better management. And if you're able to contribute to iGates as well. And feel free to get in touch if you have any questions. So thank you again for listening. And I look forward to hearing the rest of the speakers.
think, Annette, this was excellent and a very good overview of ophthalmic trauma and some of the research which is happening in this field. Over to you, Dr. Marian, for that.
Yeah. Any other comments or questions from the panelists?
I think wonderful presentation by Annette, and they're proud of you in APOTS and all over the trauma world. And I think, as you said, two highlights. One is we are working, and Rupesh is in the heart is advocacy for making this cracker as something as a public thing. And actually, I'm trying to make as a president of All India, I made a committee where we are trying to work on PIL. That means PIL is public interest litigation to stop bursting crackers. And I think our Prime Minister also appealed in 2014 that don't buy crackers from China, but buy from India. But I want to tell you, as Diwali is a festival of lights, and why should we use crackers? And then I think the Rupesh has compiled, and we have actually signed up in December in the Ocular Trauma meeting where we had the World Ocular Trauma. We have signed the petition, and we requested Dr. Ashok Grover and Dr. Mukherjee to hand it over to the Government of India, and we request now Dr. Mukherjee to work on that. So one president from past president to president of the Trauma Society. Dr. Mukherjee.
Dr. Mukherjee, would you like to say something?
Actually, we have given one RTI. It is in the formative stage, and we have collected the signature during the World Congress of Ocular Trauma, as Natarajan told, and this is in the process, and we are going to submit this one. But I will tell you one thing: Delhi High Court has passed an act that they have reduced the time of fire cracking burning during the Diwali and previous 2 days and 1 day after that. And it was passed in about 2 years back. And subsequently, last year we have seen, that is 2019, that we have seen that incidence of burn as such has reduced in Delhi in major hospitals. And also the ocular trauma incidence has reduced because they have fixed the time between the 10 o'clock to 12 o'clock, almost like, if I remember that. And it has to be a community place, not in anywhere anyone can burn those firecrackers. This is the way one can advocate the prevention of ocular trauma following firecracker injury. And third thing, that is very difficult to bring in legislation because a lot of people are involved in this manufacturing these firecrackers. So they will be jobless. So that is a major point that was discussed in one of the meetings from the government side, and we represented there, and they said that this is a major problem. That is, their lobby is so strong that where we are going to put this one. So they are thinking of bringing up something green crackers. I do not know about the green crackers. What is green crackers is going to come in, and that is to be implemented most likely in 1 year or 2 years so. So that is what is the present position of the firecracker injury, what we have done so far.
Thank you, Dr. Mukherjee. I think we will just move on to the next session. This is a much awaited and a thrilling session we are having. All the videos are of very good quality, and it is a competitive session, and the best presenter will get highly attractive cash prizes. First, we will hope all the judges are ready with the marking sheet. So now let us start the video session. First, I will invite Dr. Richa from Hyderabad to present her video, Finding the Culprit. Dr. Richa, please.
Thank you, Dr. Marian. I'm just sharing my screen.
Yeah.
Dr. Richa, you would like to play me to play the video?
No, I think I'll be able to manage from here. Just give me a moment and yeah. Is my screen visible?
Yes, screen visible. Can you make it full screen?
Yes. Just a minute. Okay. Please tell me if this is audible.
Yeah, audible.
This video titled Finding the Culprit demonstrates the approach to an orbital foreign body lodged close to the ocular surface. A 20-year-old laborer presented with red eye to the emergency, giving history of trauma with projectile particle while grinding stone one day prior. Vision in the right was 20 by 600 and in the left eye was 20/20. A straightforward linear scleral tear with vitreous hemorrhage was noted. But considering the history, a scan was ordered to rule out any ocular foreign body. CT imaging showed no gross evidence of intraocular foreign body, but a definite discontinuity of the globe was noted, with a well-defined hyperdense shadow inferior to the superior rectus posterior to its insertion, whose attenuation values were similar to bone. This was suggestive of an orbital foreign body lodged close to the ocular coats with a small intraocular component that was picked up on B-scan. So how did it reach there? We postulated that the foreign body followed a course as depicted in this model, leading to a perforating globe injury with entry and exit wounds as depicted. So a decision was made to close the entry wound, that is scleral tear repair, along with pars plana vitrectomy with exploration of the area around the exit wound. Tear was sutured with 80 vicryl interrupted sutures after peritomy and clearing of tissue. The first priority of this surgery was to restore globe integrity. Hence, only a limited area beneath the superior rectus was chosen to be explored, during which no foreign body was visible. So a pars plana vitrectomy was carried out as planned. Vitreous hemorrhage was cleared, and the exit wound with the surrounding retinal detachment was sealed with endolaser, followed by fluid air exchange and silicone oil injection. Post-operatively, retina was attached and scleral tear had healed well. So it was now time to manage the orbital foreign body. Evidence suggests that all organic foreign bodies, symptomatic and complicated cases, anteriorly located inorganic foreign bodies should undergo surgical removal. In our case, considering the history of trauma while grinding stone and the no CT scan, it was most likely an inorganic foreign body with either metallic or non-metallic origin. Considering its anterior location, surgical removal was indicated. Certain aspects to consider were recent history of open globe injury that was 3 weeks post intraocular surgery. Capsule formation around the foreign body was likely in the stipulated time period. Also, previous attempts at foreign body retrieval had been unsuccessful. So, imaging was done to confirm the presence and the exact site of the intraorbital foreign body. Also, the ocular coats were well defined, suggestive of an intact globe post-surgery with absence of any intraocular remnants of the foreign body. Now, traditionally, the approach to such a location can be via an anterior or a medial orbitotomy using these conventional incisions as depicted. But the peculiar intraconal location of the foreign body close to the eyeball prompted us to use a modified transconjunctival approach with disinsertion of the superior rectus to retrieve the foreign body. Under general anesthesia, subconjunctival lignocaine was infiltrated. Peritomy extending over the superior half of the limbus was done along with a tenotomy. Superior rectus was hooked and tagged using double-armed 60 vicryl partial thickness interlocking sutures to secure the muscle. Disinsertion of the muscle was carried out, leaving a 1 mm of residual stump, taking care to maintain muscle orientation. Relaxing incisions were given on the conjunctiva, along with hooking of the superior oblique to achieve a better exposure of the superonasal quadrant. Blunt end of a periosteal elevator was used in an attempt to feel and localize the foreign body. Initial attempts with dissection carried out towards the globe could not locate any foreign body. So an intraoperative review of the CT scan showed that was noted more underneath the muscle belly than towards the eyeball. Thus, we redirected our plane of dissection along the same course, that is underneath the muscle belly. This revealed a glistening fibrous capsule in the Tenon's tissue that was surrounding a well-defined foreign body. On gross examination, It appeared to be a stone measuring 5 by 5 millimeters with an irregular surface and metallic deposition, confirming that it was an inorganic, non-metallic foreign body. Further exploration of the area was done to rule out any residual foreign body particles. Partial thickness scleral bites were taken at the insertion of the superior rectus for its reattachment. Pupil was round and regular throughout, and globe integrity was confirmed at the end of the procedure. Conjunctiva was reposited back and secured in place using 8-0 vicryl interrupted sutures. 3 weeks post-operatively, the vision in the right eye was 20 by 100 with good ocular motility. The points to drive home are: the temporary disinsertion of recti muscles is an option to approach the intracorneal space. In addition, such an approach leads to minimal manipulation of orbital tissues, staying close to the eyeball surface. An image-based navigation protocol can be used in such cases to increase the accuracy of locating the foreign body. Thank you for your attention.
Thank you, Dr. Richa, for the excellent video. Any questions?
Thank you. That was a very nice video. Our panelists are ready. I'll start the discussion. Actually, if suppose that was a glass foreign body, would your management have been, can it be left there itself? Just one query, since...
So the glass foreign body is also an inert foreign body relatively, but depending on its size, shape, and how its edges might be sharp. So depending on that, and if it was such an anterior location, it would be preferable to remove it.
Yeah.
Although management is controversial.
Yeah.
So.
I think a glass foreign body on the surface of sclera, I don't think I will look for it. But Mahesh?
Yeah.
No, if it's a glass foreign body outside the core,
yeah,
I will not disturb that. So the glass, and even in the vitreous cavity, many times if it is not producing any damage, we don't touch it unless it produces a retinal trauma or produce a retinal tear, which will produce retinal detachment. But I think outside it may not.
Outside you have to give to Dr. Ganga. We should get comments from Dr. Ganga. Outside is not not our area. We'll hear from Dr. Ganga what he says.
Now, compliments on the video. It is nice. Just a question. I'm ignorant about anything inside the eyeball. I know the primary goal here was to repair the open globe injury, which is perfectly fine. If this was a fairly large or small posterior globe wound of exit, and even preoperative imaging showed the majority of the foreign body was outside the eye than inside the eye, did you have to go do aggressive efforts to try to remove it from inside the eye? Or should your goal have been just primarily let the globe seal first and then go for it extraocularly in the first sitting?
Thank you for the question, Dr. Ganga. So that's exactly what we planned for. So first we aimed for achieving a globe integrity. So he underwent a scleral tear repair, and we did pursue some initial attempts to find the foreign body, because depending on the scan, it seemed quite anterior and easy to access, but we couldn't localize it at that moment. So then we performed a vitrectomy to rule out the intraocular component. But by the time we cleared the vitreous hemorrhage, there was no intraocular component that was noted. So probably during the manipulations, it must have exited the globe completely.
Was it absolutely necessary, the pars plana lensectomy and vitrectomy in the primary sitting?
You are right, and it's many times, even I had patients like that, you don't find the foreign body. We didn't find by the oculoplastic surgeon, even in Dr. I think Rupali was there. It was external, we couldn't locate. We did a repeat CT, and then finally, third surgery, we removed it. And that was again an iron.
But here there was a retinal detachment surrounding. So I think Dr. Guru Prasad wants to say something. Yeah.
Actually, I just wanted to make a comment.
Yeah.
If one can be sure about the location of the foreign body in terms of which part of the foreign body is outside the eyeball, outside the course of the eyeball, if most of it is outside the course of the eyeball, then set, and then probably address the foreign body from outside with external approach and remove the foreign body, which results in less loss of extraocular contents.
Yes.
In case otherwise, if you have done a vitrectomy in the first place and tried to remove the foreign body and failed in the attempt, then in the second attempt to remove the foreign body from outside, to see exit wounds. Therefore, I advocate that you wait unless there is the
Sir, it is not very clear, sir.
reason to operating the beginning itself, for example, end of the foreign body from outside with leakage of vitreous. In fact, the vitreous will be plugging the external wound of exit if it is a small exit wound, and I think that is the best way to approach. All this provided you have proper imaging and you're sure that most of the foreign body is outside and not inside the course.
Yes. Thank you all. I think in short of time, we will move to the next video. Dr. Karthikeyan. He is presenting Traumatic Train, a journey of repair from iris to ILM technique of managing anterior and posterior segment manifestations in closed globe injury. Over to Dr. Karthikeyan, please.
Yes, thank you, ma'am. Am I audible?
Yes.
Yes. Are my slides visible now?
Yes, yes. Can you make it full screen, please?
So, good morning, everyone, and I would like to thank everyone for giving me this opportunity. Today, I'm going to present about the traumatic train, an interesting case of closed globe injury. I myself, Dr. Karthikeyan, and my corresponding author is Dr. Naresh Babu, HOD, Arvind Eye Hospital, Madurai. So this is a case of 17 years old male presented to us with an injury with the iron rod 1 month ago. His visual acuity in the right eye was 2/60 and left eye was 6/6. So on examination, the left eye was perfectly all right, and the right eye showed a congestion in the conjunctiva. Anterior chamber was showing hyphema measuring about 2 millimeter, and there was some dispersed hemorrhage in the anterior chamber also. So iris, we could make out some dialysis in the iris, but we could not make out the extent in the first sitting, and lens and fundus was not accessible during due to the hyphema. So we managed him conservatively. So after 1 month, his best corrected visual acuity just improved to 5/60. Anterior chamber hyphema has regressed, and iris showed a dialysis extending from 4 to 6 clock hours. So the lens was showing traumatic cataract, and fundus revealed a vitreous hemorrhage inferiorly, and traumatic full thickness macular hole was seen. And the macular hole was measuring about 1034 microns, and there was a SRF around the edges of the hole. So we planned for iridodialysis repair, cataract extraction with IOL implantation, and pars plana vitrectomy, internal limiting membrane peeling with sulfur hexafluoride injection. So this is a video. We already made a peritomy from measuring from 3 clock hours to 6 clock hours. Then anterior chamber entry was made with paracentesis entry was made with the keratome. Just opposite to the iridodialysis. Then the posterior synechiae was released with iris repositor, and capsular rhexis was performed. It is always better to perform the capsular rhexis before the iridodialysis repair to avoid the damage of anterior lens capsule. Then the anterior chamber was filled with visco, and with the help of 10-0 polypropylene iridodialysis repair, we just inserted just 1.5 millimeter away from the limbus where it corresponds to the iris root insertion, and the iris root was engaged, and the needle was just kept in the anterior chamber. In other hand, we just introduced the 26 gauge needle into the anterior chamber, and the iridodialysis repair needle was just inserted into the lumen of 26 gauge needle, and then it withdrawn out of the main port. So again, the needle which was withdrawn is it was just again with the same needle we just introduced into the anterior chamber and engage the other part of the iris root, and then it's drawn out, and the curtains were sutured, and it was nicely buried under the sclera. So the iris thing was done now. Then after that we went with hydro dissection. After the hydro dissection, actually the cataract was soft as is a young male. So we plan to take a cataract and cortex with the Simcoe cannula only. So we didn't use any phacoemulsification for this case. With the Simcoe cannula only, we just aspirated the as well as nucleus. Then after a complete removal of cortex, we just implanted the foldable IOL into the bag. So after filling the visco, we just implanted the IOL into the bag. Then for any vitreoretinal interference, we just suture the main wound. So after suturing the main wound, we just put a 23 gauge port. 3 ports were made. Then anterior vitrectomy was done. So after that, we did a core vitrectomy. After core vitrectomy, the vitreous was stained with the triamcinolone acetonate for a better visualization of the vitreous. So tricot assisted PVD induction was done here. So after the PVD, the meticulous removal of a vitreous done with a base dissection. So after removing all the vitreous from the eye, the ILM was stained with 0.05% of BBG. The capsulotomy was done with the cartridge. Break noted peripherally, that was lasered. There was people was closed on tape. So now we inject 200%. Okay, was so post-operatively the patient was doing fine. Anatomically, the pull was
Ma'am, I think his internet is weak. Yeah.
So Navneet,
hello?
We are having challenges to view your video. What you can do is probably just sum up, otherwise, in the best interest of time, because we are not able to see your video.
Yes, Dr.
Hello.
Yeah.
Voice is also
Can you hear me, sir?
Yeah. Karthikeyan, yeah, we can hear you.
Can you hear me, sir?
Yeah, you just present.
Yes, sir.
Yeah. You can sum up your video findings.
Yes, sir. So this is a video. This is from 3 to 5. Already the peritomy was done. So where I left, sir?
No, time. Hello. You can sum up your video.
Hello. Yes, ma'am.
And just sum it up because your time is over.
Yes.
You have to just sum it up. If you want to just sum it up.
Okay.
Something, yeah.
Yeah. Just with the iridodialysis repair. After that, then IOL was done. Then the macular surgery was done. So just we closed up the case.
Okay.
So that's all, sir. Thank you, sir. Yes, sir.
Dr. Mahesh, can you start the discussion?
Yeah. Actually, I am just looking at some other questions also. In the meanwhile, the comments from the panelists you can have. There are some questions also which I am just trying to look up.
I think there is possibility of spontaneous healing of macular hole. Following anti-segment management, we could have taken some to allow the
yes, sir, that is my last
macular hole.
Yes, that's my last point. Usually we wait the median closure of spontaneous closure is 6 weeks, and the points unlikely to closure like a lab hole. It's 1,000 microns a year. These 2 points were against the spontaneous macular hole. That's why we waited for 6 weeks. then we went for the surgery, sir.
Yeah. And many of these large macular holes, even though they close, unlike an idiopathic macular hole, there will be atrophy in that area. The visual outcome may not be as good as senile macular hole.
I think what Dr. Mehul was saying is that it was Mehul, isn't it? I mean, what he was saying is that he would prefer to do it as a two-stage procedure rather than a single-stage procedure, right, Mehul? That's what you were telling.
Yeah. Because it may heal up to 6 months or so.
Yeah. So the thing is that as far as macular holes, I think Nati also can and Guru can comment. As far as traumatic macular holes are concerned, there are a subsect of macular holes where there is total atrophy around the hole. And these are cases probably where there is not really much purpose in operating. So basically, we have to study the topography of the hole and the anatomy of the retina around the hole. And if there is significant atrophy around the macular hole, there is not really much purpose in operating these sort of cases.
Sir, are there any OCT signs which will tell us this hole is not going to get benefited? Because we do understand there were certain signs which were say, and which will be good for general ophthalmologists to know that these patients are not going to get benefited.
So that's what I said. When there is atrophy around the hole, where you see that the edges of the hole, there is a total loss of retinal tissue, and the retina is so thin. So basically, that there is not only it is not a macular hole because of the it is mainly the impact has caused some degree of vascular occlusion, and sometimes we also see a choroidal rupture at the edge of the macular hole. So these are situations where probably they not much purpose in operating on the macular hole.
Rupesh, a few more things. Actually, if the choroidal tear is there, at that area, there will be a traction pulling the retina towards that. So even if you do an ILM peeling, the hole may not close. The second thing that I think that the fundus autofluorescence is useful in these cases because it shows atrophy around that area. Prognosis may not be very good. RP damage is there. So these two things, I think, will decide the prognosis of macular hole.
And what about an amniotic membrane graft? There's Stanislaw as
no experience.
Okay. Rupesh?
Lot of things, Rupesh, lot of things are being stuffed into the macular hole.
Anyway, I agree with both of you that visual prognosis is a problem. Even close.
I think one video is coming up on that, I think.
Okay.
We will move to the next video in short of time. I invite Dr. Nandini from Bangalore to present her video, Brittle Corneal Perforation and its Management. Dr. Nandini, please. Yeah.
Yes. Good morning, everybody. I feel myself blessed to present on this forum. And here is my video. Navneet, please.
Yeah, I'll play. Yeah, ma'am.
Corneal tears and lacerations constitutes a significant cause for vision loss and ocular morbidity. Depending on severity of injury and extent of ocular damage, these eyes can be saved and sometimes not. When these injuries happen to a brittle cornea eyes, can they be saved? Brittle cornea is certainly a special challenging scenario for a cornea surgeon. It's a rare connective tissue disorder characterized by extreme corneal thinning with fragile cornea, blue sclera, high myopia, and retinal detachment. It can be associated with other features like musculoskeletal abnormalities and deafness. Till now, there are 60 only cases being reported in literature. Initially, this was seen among Tunisian Jews. Later on, reported even in European and Asians also. Brittle cornea syndrome results due to abnormality in genes essential for assembly of collagen fibrils, mutation of which results in cornea that are unable to bear normal biomechanical stress and cannot maintain their shape and structural integrity and are more prone to spontaneous rupture. Let us look at few reports in literature of brittle cornea. One case reported intraoperative extension of corneal tear from existing corneal tear in a case of brittle cornea. cornea, and this happened during the burying of knot, warranting a scleral patchcraft to seal the rupture. In another case, cheese wiring of the suture through the brittle cornea resulted in track leaks in the immediate post-op day, needing re-intervention. In this case, due to inability to suture the ruptured brittle cornea, a tectonic keratoplasty was performed to restore the anatomical integrity. Thus, in short, it is evident from the literature that suturing the brittle cornea is a nightmare. It is technically challenging to suture such corneas, and if you do anything less than a perfect job, makes these eyes non-salvageable, causing permanent loss of vision and disfigurement of face. Our video aims at teaching and providing tips in handling such corneas. It will also demonstrate about correct suturing technique and surgical steps that can be customized to this special case scenario. We shall discuss these following a case. A 3-year-old baby girl presented to us with sudden history of inability to open her eyes. On examination, right eye revealed corneal rupture. She had similar history in the other eye followed by visual loss. She also had blue sclera, and systemic examination revealed hyperextensible joints. Now, let us look at the precautions we took during her surgery to achieve best surgical outcome. In brittle corneas, tears can be large and irregular such that the extent cannot be made out, and tear wound might extend on table due to poor scleral rigidity. So, best to operate these cases under general anesthesia. Before we proceed with suturing, we have to remember the following things. These corneas are buttery and has no resistance, and these corneas can easily get torn off while handling and may even can mince or cheese wire. So be gentle and meticulous while handling these corneas. Most of the times, the perforations can be very irregular in shape and are difficult to secure. So your surgical speed should be in slow motion so that you would not be iatrogenically increasing the extent of tear and would be tackling the tear under your control. We prefer to use a guarded speculum so that there is no undue pressure on the globe. Side port entry should be guarded and slow. While making the entry, you can take support from the same side of conjunctiva. Be meticulous while releasing iris from the wound. You can release using either saline or visco or iris repositor. Do not hold the cornea while releasing the iris, as it might increase the extent of tear. And do not release everything at once. And in between suturing, you can release iris part by part. Visco inside the AC should be minimal enough to separate iris from the tear wound. Do not inject too much visco, as it can increase the intraocular pressure and can propagate the extent of tear. Suture bites can be longer and deeper. Pass the needle in single entry rather than multiple. Better to support the wound rather than holding the edge of the wound, as it might cheese wire while taking the bite and leading to wound leakage. Take support on opposite conjunctiva while taking suture bite. We can take multiple rather than tight sutures. Tension of the suture should be just adequate to oppose the wound and not to compress the wound. Before burying the knot, make sure that the knot is small and compressed. You can use viscoelastics to facilitate knot burial. Air is preferred than saline, as saline may not stay inside, as wound may not be watertight and side port may tear. Air tamponade also helps in application of fibrin glue to the wound if wound is not watertight. Once intraocular pressure increases, it might cheese wire the cornea if suture becomes too tight. Hence, monitor the globe for hypo and hypertonicity while forming the anterior chamber. To conclude, this video highlights the important steps and the necessary surgical precautions to achieve well-opposed corneal wound in brittle cornea, which would aid not only the cornea surgeons but even general ophthalmologists who may have to tackle such emergencies.
Beautiful video. Teaching video, very nice. Yeah. Rupesh, you can take over.
Okay. Thank you, Dr. Nandini. This is a very interesting video. How many cases probably you would have seen of brittle cornea cases? Have you encountered many cases or your institute?
So this is the only one case which I saw in this 5 years.
Fortunately, this is not that many. I had done few cases, and I'll tell you the biggest nightmare. On table, you will feel you have done a great job, and next day you will see all the wound, all the sutures are very loose, and the wound is leaky, and you never feel it on the table. On the table, you feel that you've done perfectly fine and all. So what is the point from you or Dr. Himanshu or Dr. Rohit about how do we kind of judge how best, what is the wound tightening? You mentioned that wound, the sutures can be a bit longer, should be not tight and all, because the standard books describe it for the standard corneal wounds. We don't know really about this kind of fragile cornea and all, what will happen next day. What is your kind of any suggestions from whatever experience or whatever teaching we had?
So, to be honest, I have no experience in suturing a brittle cornea, but I have seen Dr. Himanshu doing this case. Myself, I have witnessed the case. So that's what he was suggesting. We should be, first of all, we should be very slow in handling these corneas because we might increase the extent of tear if at all we manipulate or if he doesn't handle it very gently. That is one thing. Second thing is never hold the cornea unless it is very necessary. And as you mentioned, once you take the suture bite very carefully, the tension, whatever we put, it should be just adequate to oppose the wound. And when you are burying the knot, also we have to keep an eye, because I already mentioned one report in the video that there was an increase in extent of tear when they buried the knot. Okay, so for that you can use visco. Once we bury the knot, then forming AC is another important challenge here, because that also might increase the tear. So we did it with under air only, not saline. And if the wound is not very watertight, you feel you can use fibrin glue on table to make the wound more stable.
Yeah, so these are really very good points. So a couple of more practical points. Let's.
When you start suturing,
I have to make 2 observations here.
Yes, sir. Please.
One observation is that in such conditions, this brittle cornea or the thinning of the cornea, particularly in the type of cases that you have seen, pellucid marginal degeneration, also the similar type of thing can develop. So my observation is that one should not try to go through that wound repeatedly, because as such the cornea is very brittle in that area. You make side coat, and whatever maneuver you do into the anterior chamber, you go through the side coat rather than going through that wound. Second point that I would like to highlight, that we were also telling, that you feel great after the completion of the surgery. In such condition, one can do 2 things. One is one can apply 1 or 2 indirect sutures, taking the bite from the healthy cornea little bit, and then go to the other way, rather than going through and through sutures. This is the one point. And another point is that after application of the suture, one can apply, if you have doubt on those cases, apply a little bit of fibrin glue, so that the wound is secured for at least some time, for the time you have given for the formation of the anterior chamber and initial part of the healing.
Thank you, Dr. Mukherjee. I think we will move to the next video by Dr. Giriraj. Trauma not so traumatizing anymore. Over to Dr. Giriraj, please.
Hello. Am I audible?
Yes. Can you share your screen?
Yeah, ma'am. I would like to thank my teachers and APOTS and the Giridhar Eye Institute for organizing this. I'll move on with the video. Is my screen visible?
Yes, yes.
Operating in traumatic RDs is already difficult. On top of that, if we don't have enough view, how can we do our job? Presenting a series of such traumatic cases which were operated successfully through small zone of visibility, which we call as window of hope. The point depicted here is the surgeon without the view is trying to operate on a difficult case. This was the story of a young boy with a firecracker injury. We can see very small zone of clear cornea through which we had to operate. Corneal tear was repaired and after 1 week, vitrectomy was planned. You can see there is RD with a tear. DVD injection was difficult. We had to trim the rolled edges of the brain. Fluid exchange was done to reduce the velocity of the retina. PFCL was used to flatten the retina and fluid air exchange was done, and we can finally see the retina settling well. Silicone oil tamponade was given. The surgery was completed successfully. This case was of domestic violence where husband accidentally hit his wife with the tip of an umbrella. The corneal tear was sutured, cataract was removed, and then you could see this. It was very challenging to go ahead. We had called this as retina or spider web. After removing the membranes, PFCL was injected to flatten the retina. Retinectomy was performed at the site of incarceration to relieve the traction. Anterior EVR was dealt with. And fluid air exchange was done. Silicone oil tamponade was taken. Luckily, the patient is doing well and maintaining good vision. Defeating the devil of domestic violence. Surgeon with compromised view is like Iron Man without his armor. So this was another firecracker injury. Actually, this boy was an innocent bystander. He was standing and watching. Somebody else was lighting the firecrackers. Corneal tear repair was done, and after 1 week, vitrectomy was performed. Because of vitreous hemorrhage, it was very difficult to identify the structures. Iris hooks had to be used. There were multiple attempts to induce PVD, but we were unsuccessful. In the end, finally we could induce PVD after a lot of struggle. After that, we could see there was traumatic subretinal hemorrhage and a peripheral shallow RD. PFCL was injected to flatten the posterior pole. Fluid air exchange was done. do the peripheral break, and laser was applied. Finally, silicone oil tamponade was lifted. This was a case of tile cutter who presented to our emergency department at 12 a.m. in the night. We could see the tile piece had halved his eye. The foreign body was removed, which was measuring around 14 by 11 mm. Meticulous corneal suturing was done, and now we were ready to dive in for better time. Again, because of vitreous hemorrhage and RD, we were not able to make out the anatomy clearly. TFCL was injected to flatten the retina, but it started entering subretinal space, so we had to resort to retinectomy. To relieve all the traction possible, submacular hemorrhage was cleared, and finally the retina settles well after injecting TFCL again. We secured our focus by laser, and this was the site for our sore eyes after the challenging surgery. Macular status was confirmed with intraoperative OCT, and the patient is really doing well. You can again see the small window of hope through which surgery was done. The patient is really happy that we could save his eye. With modern technology, trauma doesn't seem so traumatizing anymore. Thank you.
I think a very good presentation. Just to say that I think like not to give up, and it's not. I think your conclusion is not so traumatizing. That I think looks like technology is improving, but still a lot of eyes may not be salvaging. But I think good is to attempt. And that to attempt with sincerity. I think great job done.
Thank you, sir. Thank you. Thank you so much.
Any comments from the panel? Actually, the timing of surgery is very important. If there is a little too much delay, it becomes inoperable in many cases. The timing of surgery after a couple of weeks of primary repair, that is extremely important. Guru Prasad sir, anybody? Giridhar sir?
I think you're absolutely right, Mahesh. I think 10 days. I would not like to operate a patient after 10 days. Rather, I mean, it becomes very difficult after 10 days. As you said, PVR is so severe in these traumatized that and especially with the problems of visualization, like Giridhar showed, of corneal opacities right in the center, precluding all view. In fact, we have to operate with a very limited view. In fact, one of the lessons from this presentation is that whatever may be the corneal opacity, however bad it may appear, we should still try and do. And most patients, in fact, yes, these 4 patients has been
we can't blame you. Guru Prasad, I think I have
we should all know. After repairing them more than 10 years.
So basically, Dr. Guru Prasad is saying very right thing. And what I gather is he's saying irrespective of the corneal opacity, we need to take an active step and operate and should not delay it. So Mahesh and all the panelists, what I'm suggesting here is this is something area which Mahesh, we used to struggle also during Shankar Netralaya days, and it all depends on the surgeon's appetite. Depending on how aggressive surgeon is or conservative surgeon is, then it will matter, and accordingly we'll use to take those cases to those surgeons. it should not be too many surgeon factor coming into picture. And if we can standardize across globally in some way, I don't know how we can do that. But I think this is a very important controversial area which need to be answered. Is it should not be too late, and how you can address with all this stuff. Yeah.
Okay. Current school has made a, I don't know whether he's published it. He is now recommending instead of waiting 2 weeks, better to do it in 6 days, he says. He's arrived at 6 days, which is, I don't know how he has done it. But I think it's a good point to do, Rupesh. I think we should evaluate this and come to an international understanding. I think I think practically I feel within a week is important, however bad, because too late, I think too late will be 7 days.
Yeah.
I think 7 days, and whatever you can do, you can even attempt a third surgery. But I think 7th day, if you do, there is a possibility of whatever possible little PVD happening, corneal edema clearing. You wait too longer, cornea also may not clear that much.
Yeah.
From 7 days to 9 days.
Okay. Thank you all. I think next we'll move on to the next video. Dressing up the macular hole by Dr. Alpesh Rajput. He is from Ahmedabad and having his own practice, Rajput Eye Hospital. Over to Dr. Alpesh, please.
Thank you very much. Am I audible?
Yes,
Yeah.
yes.
Yes. Mr. Navneet, please share my video.
Yes, sir.
Yeah. I am thankful to Ophthalmic Trauma Society to giving me this opportunity to present my video. So on behalf of me, Mr. Navneet will share my screen for the video. So kindly go through it and no, that's not mine. That's not mine.
You must have spent some time in Shankar Netralaya. Therefore, they are
Just a minute, sir.
putting you back.
Yeah, I love to spend there, but I was unable to do. So I was with the Giridhar sir, and I am
actually going there. Virtually, you are getting into there. You know,
I am extremely happy that I learned from the Dr. Giridhar and Dr. Mahesh sir. What I am here is right now only yeah. Mr. Navneet, can you play now full screen? Yes.
Sir, this is the one?
Yeah, this is the one.
Yeah.
Here we are presenting various stuffing materials for macular hole vitrectomy surgery. We tried various dresses to cover the open body tunnel of macular hole and make them beautiful and healthy. After doing core vitrectomy and triamcinolone stained posterior vitreous detachment, all cases were tried to complete reasonably large and non-traumatized internal limiting membrane peeling without damaging other layers of retina. We did inverted internal limiting membrane peeling and stuffed the ILM over the bare macular hole in multiple layers. We did inverted internal limiting membrane peeling and stuffed the ILM over the bare macular hole in multiple layers. Here temporal ILM flap is created and rolled over the macular hole, covering it nasally even with the multiple layers too. Temporal pedicle graft was kept secure in place with the help of viscoelastic material, and later fluid is exchanged with the air. used autologous conjunctiva graft to see the effect on anatomical closure and physiological outcome on the macular hole. It shows good anatomical apposition by feeling the gap, but physiological output in the sense of visual acuity was not remarkable. We have tried wet amniotic membrane graft in few cases, hoping that it will provide scaffold to the surrounding retinal tissue, which can later grow over the amniotic membrane graft and ultimately leads to successful closure of the macular hole. We did use posterior capsule of same eye for dress up the bare macular hole. Posterior capsule was isolated with vitrectomy cutter and picked with the ILM forceps. Autologous posterior capsule graft was placed over the macular hole with the help of viscoelastic material and fluid air exchange completed, and C3F8 gas was injected at the end. Autologous whole blood is taken as sample. Centrifuge process was done. Upper yellow part of centrifuge sample was taken in tuberculin syringe and 5 to 6 drops used after fluid air exchange. Excess amount of platelet-rich plasma is aspirated and C3F8 gas was injected. This plasma will provide growth factors for the regeneration of neurosensory retina and ultimately leading to closure of the macular hole. We used autologous retinal graft for closing large idiopathic macular holes, as in all cases after completing good enough size of the internal limiting membrane peeling. Donor area was selected along superior artery or nasal 2 disc. First donor retinal area was lasered in circular manner. Internal cautery was applied over the densely lasered part. We took comparatively large graft in this case, keeping in mind that graft may shrink in post-operative follow-up. Horizontal micro scissor was used to separate the donor retinal graft from the underlying choroid, making sure keeping some part of circular retinal graft attached at the periphery. Now the perfluorocarbon liquid was used to stabilize the retinal graft. Now the perfluorocarbon liquid was used to stabilize the retinal graft. Two internal limiting membrane microforceps were used to grasp the donor retinal graft. Care was taken not to touch smooth vitreal part and irregular retinal side of the central part of autologous retinal graft. Finally, graft was kept over the macular hole area. Fluid and PFCl was exchanged with air and C3F8 gas was injected and prone position was maintained strictly in all cases post-operatively. We used autologous retinal graft hoping that this will fit snugly. It can rebuild and restore the macular structure by disintegrating in nearly all retinal layers in longer follow-up, will ultimately resulting in functional improvement as visual acuity in future.
Thank you, Mr. Navneet. Yes, sir.
Yeah, thank you, Alpesh, for the nice videos. In fact, a lot of papers are there regarding this different materials to stuff the macular hole. Unfortunately, there is no good evidence that one is better than other.
Better than the other.
Yeah, that is a thing. We can't tell, okay, this is the gold standard. Probably retina tissue itself may be a better thing, but I don't know. I don't have any experience. The one thing that I thought was this taking the graft close to the nasal side of the disc may not be very, a little away from the disc towards the equator will be better, so that the field effect due to the retinotomy will be less. Anyway, comments from others, Giridhar sir and other retina surgeons?
How do you decide what to put?
That is a very important.
So, I want to tell, I have taken few grafts just superior to the arcade. That will be near macular structure, we can say. The near the macula, we will get the most amount of the retina, like the macula, we will try to get.
Okay. That is one argument.
Yeah, that is what we can do, I think.
Dr. Alpesh,
Yes,
what is
sir.
the cutoff for the grafting or whatever material you use? Most of the holes that you showed were very small, not very big at all. I think you should have a cutoff beyond which you will probably use a graft or some material to stuff. And I want to know what happened to the case in which you used conjunctiva.
No, that was close, but reason is, I think I have already mentioned, it is only counting figure 3 meters, sir.
So, what is the rationale first of all, and what was the result in that?
No, I am trying to remove that conjunctiva. We will see. I will do the follow-up for the 1 year. What is happening to that case? That is what I am trying to do, sir.
If you have the immediate post-surgery OCT, is it possible to show it? Because
right now it is not possible as of now, sir. So I will share it. I will share it later, sir.
But this was not traumatic cases, right?
Yeah, this was the few are traumatic.
These are not post-traumatic cases.
Not all are post-traumatic, sir. Few are traumatic only. Yes, sir.
Thank you, Dr. Alpesh.
Thank you very much, ma'am.
Yeah, I'm sorry. There's a small change in the program. Just note the judges also. Since Dr. Kendrick has to leave for another webinar, we will have the second keynote address now. It's my great pleasure to invite Dr. Gangadhar to introduce Dr. Kendrick to the viewers. Over to Dr. Gangadhar, please.
Thank you, Marianne. Before I move on to introducing Dr. Kendrick Shi, I would like to take this opportunity to actually thank Dr. Giridhar and Dr. Marianne Pauly for persisting with their efforts to try to get this ophthalmic trauma conference going. It was dreamt of last year, I know how disappointed the organizing team was when the COVID hit, but he persisted and persevered and decided that even if the COVID hits them, we will not postpone or cancel this meeting, but instead he reformatted the entire thing and concluded in proceeding with it. And I hats off to you all. The only thing I miss about in the webinar is the lovely hospitality and the Kerala food. So thank you, Dr. Giridhar, Dr. Marianne Pauly.
Thank you.
I'd like to introduce Dr. Kendrick Shi, our next keynote speaker. I'd like to introduce him actually as a very young, dynamic, handsome young man from Hong Kong. Ever since he's joined the Asia Pacific Ophthalmic Trauma Society, he's shown great interest in teaching and sharing his knowledge and expertise. He's an anterior segment and corneal surgeon. He's contributed a lot in our APOTS courses at the American Academy of Ophthalmology, works at the University of Hong Kong, and also works in Shenzhen in China as well. For his age, he's published a lot, does a lot of wonderful research, and has won numerous awards from various organizations, including the Asia Corneal Society, Asia Pacific Academy of Ophthalmology. I know South Asia, chemical injuries of the eyes are quite common. And oftentimes in ocular trauma or ophthalmic trauma, we talk about mechanical injuries. We don't talk too much about chemical injuries. So he's going to talk to us about emerging therapeutic strategies in the management of chemical injuries of the ocular surface. Over to you, Kendrick.
Thank you, Dr. Ganga.
So can everyone hear me? Yeah. So I'm Dr. Kendrick Shi, and thank you very much for the introduction. And I have to thank APOTS and also the Giridhar Eye Institute and Dr. Giridhar himself for the very kind invitation to give this keynote lecture. So I think, there's been a lot of really good surgery today. So my talk will really focus on what's in the pipeline in terms of translational research and what we can do for chemical injuries. I think chemical injuries, we've all managed this. It's a common and true ophthalmic emergency. It constitutes up to about 18% of all ocular trauma. It usually occurs in young men and usually related to household exposure or industrial accidents. Now, the immediate management is key. It's in terms of neutralizing the pH as soon as possible with whatever we have, water if preferable, and usually the irrigation has to be done quite sustained in order to get the alkaline pH to be neutralized as soon as possible. Now, what I'd like to focus today is on the subsequent management in terms of what we can do better, because even with neutralization, we do see a lot of these patients suffer very severe and debilitating complications of the cornea. So in terms of what we do nowadays, aside from preventing infection, adequate analgesia, what we want to do is promote wound healing and reduce inflammation and scarring. So in our armory, what we do have is prednisolone eye drops, lubricants, and some like anti-MMP activity medication like taking doxycycline, tetracycline, but is there something more in the pipeline? So this is what my talk will examine. We recently published a review on this. It's published ahead of publication. It's in Eye and Contact Lens. So if you're interested in some of the things that I'm going to talk about today, you can look into this paper that we have for more details. So I think in terms of what we classify as what are the things that we can do to promote wound healing first. So in order to have a very nice wound, what we need to do is to provide a structure for our limbal stem cells to grow. Now, the key for this is that we need to at least salvage some of the limbal stem cells in order for us to have this structure for these cells to grow on. So I think the most important thing is still neutralization of the pH, salvage as much as possible, minimize as much initial damage as possible. But what are some of the changes that we have nowadays? So amniotic membrane transplantation, we use this quite a lot as sort of putting out the fire, providing a area for growth. Now, one of the things I want to highlight is this new nanofiber reinforced decellularized amniotic membrane. So what it is it provides a more tough structure so that when you suture it, it's a lot easier. It doesn't buttonhole as easily. And the second thing is it stays much longer so that you don't have to replace the amniotic membrane. There's another a study that was looking at retinoic acid engineered amniotic membrane. The idea is that retinoic acid will inhibit MMP, although that study didn't really show as promising of a result. Now, not only can we provide an actual structure for it to grow, but at the same time, a lot of these treatments that we might provide need a vehicle. So we can provide this through extracellular matrix components or through hydrogels. So the idea is some of the treatments that you need have to stay long enough on the cornea in order for them to have its effects. So a lot of these studies have examined various hydrogels and extracellular matrix components in order to mix it with these treatments to provide better wound healing. And in fact, a lot of these studies actually showed that just by providing this vehicle, option for the cells to have a less, adverse environment. So a post-chemical injury cornea, I've almost never seen a infection occur because the environment is so hazardous, is so damaged that even the bacteria are wiped out. So the idea is by providing these components, you can coat the cornea and provide a surface for your cells to realize. Finally, you also do have these cell proliferation and repair modulators. So they work by the MAPK-ERK pathway by stimulating proliferation, but again, you still need the limbal stem cells for them to work. You have various different ways. So you have your tetrahedral framework nucleic acid. Some of these have to be applied as eye drops. But what you notice is that all of these eye drops, if you just apply it on, it's going to be washed out very quickly. So in order for it to have an effect, what you can see is that a lot of these treatments actually have a vehicle, which is usually your extracellular matrix components or hydrogels. And so I think this is still
something that we have to consider. So a lot of these studies, it's not just the components themselves, but also with hydrogel and ECM. So really whether that works by itself, whether we need additional components remains to be seen. So the other area that we also want to look at is reducing inflammation and scarring, because ultimately your cornea has to remain clear. And in order for that, you don't need the keratocytes to over-proliferate and cause that scar formation. So what can we do? You can have mesenchymal stem cell transplantation. So we know that this is very effective nowadays in systemic treatment of certain autoimmune diseases because it has an anti-inflammatory effect. And in terms of where you get your stem cells, you have your human, uterine cervical MSCs, or you can have your laboratory designed MSCs, but they also work by combining it with hydrogel so that it stays longer, or combining it with cell sheets for them to stay and exert their inhibitory effects. In terms of anti-inflammatory agents, I think one thing that we do have nowadays that can be applicable is aloe vera. We use aloe vera for burn units in terms of skin treatment, but we have also been able to show that these can also improve ocular surface growth by suppressing a lot of the inflammation. I think for these tend to be more in terms of genetic manipulation to remove certain factors that are more pro-inflammatory. So I think although knockout mice, they do show some good results like the RAP1 inhibition, but I think these are really down, sort of really away from clinical management at the moment. But this is something that is a little bit more interesting, simply because these are now commercially available. So the first one is ROCK inhibitors. Now, if you've seen some of the research in the endothelial cell replacement, you know that ROCK inhibitors have an effect that they can actually promote cell migration and also proliferation, even in the endothelium. And so nowadays, sometimes people are prescribed this eye drop after manipulation of the endothelium in order to cause it to grow. So similarly, you can also do this on the epithelium, and it can also have a similarly positive effect on this. So I think this is quite interesting because you do have commercially available ROCK inhibitors that we can use nowadays. The other one that is commercially available is the topical azithromycin. So we do have this in Hong Kong. I think the one that we get is from Thea. And so the idea is that it, aside from its antibiotic properties, it can also have some anti-inflammatory properties, as well as evidenced by its anti-apoptotic effects and also anti-TNF-alpha effects. Finally, some of the newer agents is this anti-fibrotic agent called pirfenidone. It's been used in liver cirrhosis and liver fibrosis, has been shown to be very effective in inhibiting this scarring effect. So a group in China actually showed that by applying it topically, you can reduce the corneal opacification after injury. And in fact, because pirfenidone actually has a very short half-life, a Brazil group combined it with liquid crystal nanoparticles in order to prolong its half-life. And by applying it on the eye surface, you can apply it as a less frequent dose and still achieve the same effects. The final one's antioxidants, so things like melatonin. We do know that it helps with some of your prevention of problems in your sleep, but we also do know it has some anti-inflammatory effects, and it's also found in your tear fluid. So this group also examined whether adding melatonin may help in preventing oxidative stress. It does show some promising results, but I think we have to consider whether this is really clinically viable. So just to end my talk, I think we've summarized quite a number of different studies that may actually be effective in translation to human research, but we also have to understand that there are several limitations. The first thing is that there's a limitation in how much you can actually provide the eye in terms of treatment. And the second thing is I think we also have to consider whether all of these treatments are actually complementary to each other, or whether if we combine them with each other, they might have some inhibitory effects. So I think there's a lot of treatments in the pipeline, but we have to be quite careful about what we can do in translating this to clinical research. I think if you look at some of the structures, I think in terms of amniotic membrane modifications, extracellular matrix, hydrogels. These are quite promising, as also some of the anti-inflammatory treatments that we already have commercially available. I think certainly having this Rho kinase inhibitor may be effective. So yeah, so I think that's all I have for my talk today, and thank you all for listening. And so welcome any questions, and yeah, thank you for this invitation again. Thank you.
Thank you, Kendrick. That is fantastic to share with us what's on the horizon, and you'll probably later on elaborate on how this complements what exists there. Before I hand you over to Dr. Mukherjee to give some expert comments, I'd like to introduce to our audience that Kendrick is our Joint Secretary of APOTS, a young dynamic person. He's going to be ably assisting Dr. Rupesh, so you're going to be hearing more from him. He's going to be knocking at your doors for more membership, more activities, and more contribution to APOTS. Dr. Mukherjee,
yeah, so we're also
diamond on the crown of APOTS, and I'm happy Ocular Trauma Society and APOTS are steering the whole world. And so happened from March webinars, I think I lost count how many trauma things are going on. And next week is also full of trauma. So great, Kendrick, to have you. And I hope all of them are impressed with you and they become members of both APOTS and OTSI.
Oh, thank you very much. Yeah, I hope we do have
presentation. And comprehensive presentation is a huge subject of this chemical injury. So I only want to know, how do you apply this aloe vera preparation in the eye?
So I think in terms of what's been done at the moment, it's in terms of rabbit research. So we haven't actually tried it in human trials. What we're actually trying at the moment is at a bandage contact lens where we grow an epithelial cell lining and we stamp it down so that it uptakes. So at the moment, we're working on ex vivo models and also a rabbit in in vivo model as well. But we haven't published the results yet. So hopefully that might be something that we have in the pipeline. Aloe vera, I think you can apply it directly in the eye, but the frequency, the duration, it may still have some questions in that.
Second point is that how long you will give the wash? Do you use any litmus paper or anything like that to convert the pH of the conjunctival that fluid that is there?
Yeah, so that's a very good question. I think the main thing is when we see these patients, usually they're in the emergency department. They're already being irrigated, but maybe they've given them 1 liter of fluid, but we realize that that's not enough. So we really keep on rechecking the pH until it becomes normal. And I think the key is to irrigate until it becomes normal, because if you just irrigate 1 liter, if there's not proper exposure, there could be trapped substances in the fornices, and it really does take time. So I think it's just patience and copious irrigation, just continuing to talk to these patients so that they understand that you just need to keep irrigating them until the pH is normalized.
I think if one has a litmus paper, one can try that. That's a good indicator. Another question that I thought that I will ask you, do you have any experience of using any chelating agent like acetylcysteine and all these things?
So we don't have acetylcysteine. So that's a really good treatment, not just for chemical injuries, but also for things like filamentary keratitis. But because of some production issues in Asia, we don't have that in Hong Kong at the moment. So unfortunately, we don't have much experience there.
It helps actually for some cases, acetylcysteine or other chelating agent. It helps to major extent to all these cases of alkali burden.
Oh, thank you. Yeah, hopefully we can have some experience in that.
Thank you.
Thank you
very much.
Yeah, thank you, Dr. Kendrick, for the excellent keynote.
Thank you.
Yeah. Now we will have a small corporate video from Microvision. As we know, the whole meeting is sponsored by Microvision. Over to Mr. Navaneet, please.
Thank you, madam. Yeah.
The drug Trihalon Trehalose is not only a lubricating agent, but it is also known to have antiviral properties against viruses like the Zika virus and the human immunodeficiency virus. Trehalose is also known to augment the induction of the interferons. The potential role of trehalose for ocular prophylaxis against the COVID-19 has been explained in this review article. The coronavirus binds to the ACE2 receptors on the corneal epithelium. It undergoes clathrin-mediated endocytosis followed by cathepsin-mediated degradation of lysosomal proteins, facilitating the viral RNA release. This is followed by the translation of the virus. This viral progeny are finally transported by the Golgi vesicles to the cell membrane and are exocytosed into the extracellular space. Trehalose blocks cathepsin, degrades endosomes, and augments the induction of the interferons, thus inhibiting the coronavirus.
Thank you, ma'am.
Okay, so thank you. Now we'll continue with our video competition session. Next, we will have Dr. Shreya Shah. The video is on innovative, cost-effective method to repair lacrimal canalicular laceration. She is from Rashtriya Netralaya, Dapur. Over to Dr. Shreya, please.
Thank you so much, Dr. Marian, Dr. Giridhar Eye Institute, and APODS to allow me to speak on the innovative technique. Am I audible?
Yes, you're audible.
Yeah. So today I'm going to speak on innovative technique which can be presented for canaliculostomy, and ways to injury to canaliculus are many, like direct laceration or indirect laceration, or along with medial canthal tendon tendon injury too. But 50% of are fairly asymptomatic in case one functioning canaliculus is not injured. But of course, we have to go for primary repair. Second, primary repair has to be done within 48 hours. And we have to have certain controlled condition in OR. And the step starts with location of cut, severe end, which is the difficult thing. So first thing is the inspection. And inspection comes looking for flaring gas ring reflex. If it is not able, you are not able to see, then again comes irrigating cannula, fluorescein, or any other material to see the cut end. Most of the time we are not able to see, but if you are able to see, it's better to do stent in the primary condition after confirmation by the railroading technique. And then comes with the stent position. So after stent position, direct anastomosis, pericanalicular tissue to be done. Now, if we look for the things available, which one is mini monoca, which is used very widely, but it has got certain advantages and certain disadvantages. Also, it is costly. So the thing came like in Teflon sleeve of intracath, which can be used for the stent as a after canaliculostomy, which is very cost effective, very easy to approach. It is always available in our OR. But again, everything has its flaws and cons. This can be, even secondary repair can be done by intracath. But again, it has got some flaws like local inflammation, as it is not inert material, and the most important flaws is extrusion. So people are using pigtail probe, and pigtail probe is able to locate the cut severe end. And again, if you pass the suture, you can do stent position also. But disadvantage of pigtail probe is very, very thick probe. So sometimes it traumatizes the injured canaliculus also. And the most important and the most difficult part for everybody who is repairing traumatic canaliculostomy is the finding out the cut medial end of the canaliculus from the mass. So one day I tried everything, looking for flaring gas, ring reflex and all the solutions. I could not find the cut end of the canaliculus by inspection. So just pigtail probe came in the mind, and after dilatation of uninjured canaliculus, both the probe passed, and I just took 40 Prolene needle. I broke the needle and in operation theater, and we have emery stone with us, ETO stone. So I just made that cut end of the needle blunt by rubbing it on the emery stone and made it completely blunt. So now the tip of the needle, 40 Prolene suture needle, which is half circle needle, made totally blunt, non-traumatic. And I hold it after dilatation of non-injured end of the canaliculus. I just hold it by curved needle holder and try to pass from the non-injured end. Initially, I had resistance. Then slowly I came to know that the needle is guiding us rather than pushing. So I tried that technique and I just waited, and I could see that after proper positioning of the needle and positioning of the lead by forceps, I was able to push the needle, and I was not in fact pushing, needle was guiding me, and I could see that it has come out of the cut end of the canaliculus. So I just took it out. The same suture I used as a pass through the other end, and now Prolene is ready for us to use as a stent also. And if you'll see here also, if inspect properly, the medial cut end of the canaliculus is very clearly seen. So now see the flaring gas ring reflex from where the thing is coming, you can see. Initially we were not able to see, so it's right position. After that, I just tied these two Prolene suture after suturing the pericanalicular tissue and positioning the lead properly. Once it is done, Prolene is very strong suture and slippery suture. So after tying the knots of Prolene, I just tied knot, keeping it little loose, and we just cauterize to make the end of the cut Prolene blunt so it doesn't slip. This is the same technique when I came across the child which has got, she also 2-year baby had a medial cut end of the canaliculus, and which I was not finding. The same technique I used now 60 Prolene rather than 40 Prolene, and which has got small needle after making it blunt on the table. So in this case also, I was able to find out the cut medial end of the canaliculus, and I was little expert while I was passing because I had already done 2 to 3 cases till this case I received. So after that, again I passed through the cut other end of the lead and tied. This is cost-effective, easy available, easy technique, less learning curve, surety of finding proximal end, and no other stent material additional is required. Done same procedure in 10 eyes in a year, and it was published. But again, it has got disadvantage. Because it causes the initial irritation, corneal abrasion, and sometimes Prolene is very, very strong suture. It causes the shaving of the roof of the canaliculus and also infection. And it is not useful post-traumatic stricture. So we designed, there is Drashti canaliculostomy silicone intubation set, and it is patented. It comes in 3 sizes with the same needle, blunt tip needle, and I used in both the patients, adult also, and this is a secondary repair we did with this. After dilatation of strictured canaliculus, the same thing came out from the other end. So this time I took out from the upper end of the canaliculus because the lower end was strictured. And after doing this, you need to tie 10-0 suture to both the cut ends of the silicone and just slide the knot in the canaliculus so it becomes non-traumatic. The advantage all above previous method also had, plus cost effective and easy to use, and it was used in avulsion of lid too. And the same technique I used in children also with the smaller gauze. Post-operatively systemic antibiotic, steroid and syringing. This is post-operative syringing, keeping the intubation set in the place from the side of the tube. I'm just passing the fluid and we can see the patency can be checked. So again, the disadvantage, if not used skillfully, it can create the false passage, false anastomosis also, and cannot give confirmation of surety of the right passage when both the canaliculus are injured. So, and again, to rule out the first thing which can create the false passage, we said we are coming up with the new design, and this is with the olive tip with silicone tube. So it is already patented. Thanks to my patients. Wish you all have happy patients. Thanks to my teachers. Thank you all.
Thank you, Dr. Shreya. Thank you, Dr. Shreya, for the innovative methods. Any questions from the panelists?
Maybe if there's nobody, I'll probably make a comment. Thank you for demonstrating the Indian jugaad, making do with what you have, and that's what lends itself to success one way or the other. And you've taken it further into demonstrating developing a gadget or a device which is probably easier to use. I myself am not a big fan of pigtail probes because of the variations in anatomy, and you know very well about 15-20% of them have separate upper and lower canaliculi. Would you like to qualify about structural success versus functional success in your patients, number one? And number two, would you like to compare and contrast bicanalicular intubation, which is your device, from the traditional Crawford or Rittling system in these canalicular lacerations, to the monocanalicular lacerations in terms of outcomes and medial canthal proximity? Thank you.
Yeah. So the second is actually when we do Crawford technique, we have the long probe, and I was just using the half curve of the needle just to find out the idea over here was not only the canaliculostomy or stent. The idea over here was just to find out the difficult thing which everybody is facing difficulty to find out the cut end of the canaliculus, and here we get the surety of finding out the cut end of the canaliculus. I have not compared with both the things, but we can do that.
Thank you, Dr. Shreya. I think with short of time, we'll move to the next video. PKBU by Dr. Shevin Salim from Shankar Nethralaya, Chennai. She is a fellow in the Department of Ophthalmic Plastic Surgery. Over to Dr. Shevin, please.
Thank you all for giving me this great opportunity. Navneet, can you please share my video?
Yes, ma'am. Yeah.
Thanks.
Peek-a-boo. They say orbit is a Pandora's box and full of surprises. What we see many a times is just a tip of the iceberg. We present a wooded story of a 13-year-old boy who presented with a history of injury with a bamboo stick. He underwent lower lid laceration repair with superficial foreign body removal under general anesthesia and was diagnosed to have right traumatic optic neuropathy. On examination, the right eye was exotropic, globe was intact, but patient had nil perception of light in the affected eye. External examination showed a superficial granuloma with pus pointing in the lower lid with medial ectropion. The left eye was within normal limits. The magnetic resonance imaging was suggestive of a linear hypointense tract in the right medial orbit extending into the ethmoid sinus with retrobulbar fat stranding suggestive of a retained wooden foreign body. He was taken up for a foreign body removal under general anesthesia. Intraoperatively, the lower lid abscess was drained and pus was sent for culture sensitivity. The medial orbital foreign body was approached through a transcarancular incision. An encapsulated friable wooden foreign body was identified in the medial extracornal space. On further exploration, multiple tiny pieces of the residual bamboo stick was retrieved and removed. The surrounding granulation tissue was excised. An intraoperative nasal endoscopic examination was done to look for any retained foreign bodies. A thorough betadine, antibiotic and saline wash was given, and the immediate postoperative period was uneventful. Blood agar culture showed colonies of gram-negative Klebsiella pneumoniae. Just when we had thought all was well, at 6 weeks follow-up, the patient presented with another persisting granuloma in the lower lid. Aware of the notorious residual foreign bodies that the wood can leave behind, the patient was taken up again for exploration, and we found this tiny culprit, a small splinter of wooden foreign body, which was removed along with the surrounding granulation tissue. The patient is currently asymptomatic and due for the next follow-up. Orbital foreign bodies can be divided into two types, metallic and non-metallic. Non-metallic foreign bodies can be inorganic or organic. The clinical course of orbital foreign bodies differs depending on their composition. Most metallic foreign bodies remain quiescent for a long period of time without causing any problems. So, the general recommendation is to leave them alone in the absence of specific indications for removal. However, organic foreign bodies like wood have a much higher incidence of potentially sight-threatening and life-threatening complications. The indications for an orbital foreign body removal can be easily remembered by the mnemonic SCOLD. They are large-sized or sharp, contaminated, organic, located in close proximity to vital structures like optic nerve or causing any dysfunction like ocular motility restriction. Organic foreign bodies cause an intense inflammation and infection and are the most troublesome of all. They are common in young males. The diagnosis is often missed due to vague history, especially in children, and also in view of the minimal signs of external trauma. A high index of suspicion is mandatory. The porous structure act as a nidus for microbial growth, and also they form a biofilm resulting in decreased efficiency of antibiotics. The wooden foreign bodies are fragile and hence splinter easily, often leading to an incomplete removal. Review of previous reports suggests that wood is often not detected on CT scan. The radio density of wood is variable and may be similar to that of the orbital tissues, which may account for the potential difficulty of recognition. The CT appearances seem related to the interval between injury and examination. In the acute stage, the very low density of wood can be confusing with low window settings, mimicking air bubbles or emphysema. In the subacute stage, wood assumes a moderate density and may be difficult to distinguish from surrounding orbital fat. In the chronic stage, the density of wood can become higher than that of the orbital muscle. Magnetic resonance imaging is the preferred modality of choice. It usually appears hypo-intense to the orbital fat on T1 and T2 weighted images in MRI. Sometimes we can get an interesting CT image like this, showing a cylindrical appearing foreign body with a central core of high density and a surrounding area of low density. In this case, the central high density area is the graphite and the surrounding low density is that of the wood. A thin outer rim of high radio density can be there corresponding to the paint covering the pencil. The different approaches for removing the orbital foreign body are transconjunctival, transcutaneous and or endoscopic. If the primary wound is visible or open or in the presence of a sinus tract, the approach can be through the same. Intraoperatively, meticulous removal of all fragments, careful debridement of necrotic tissue and irrigation of the surgical wound with antibiotic solution should be done. An endoscopic assistance should be sought in selected cases. They may remain dormant for a variable period of time and manifest with delayed onset orbital granuloma, cellulitis, abscess, or chronic draining sinus. Hence, surgical removal of organic intraorbital foreign bodies is recommended. To conclude, intraorbital wooden foreign bodies are notorious and can often be misdiagnosed. Preoperative imaging is mandatory in suspected cases to avoid multiple surgeries and also the risk of anesthesia. Careful intraoperative exploration should be done to look for routine foreign body, and one must have a high index of suspicion and look out for the splinters as well. Diagnostic nasal endoscopic examination shall be done in cases of sino-orbital foreign body. Thank you.
Thank you all.
Thank you, Dr. Shrevin, for the excellent video. Dr. Gangadhar, would you like to comment?
Thank you for teaching us all how often we make mistakes. And the learning point is that by default, any organic foreign body you remove, there are always more foreign bodies in there that we often missed. The only qualification I would make is just as how you emphasize the value of preoperative imaging. These are the situations where I would strongly urge follow it up with the post-operative imaging as well, just to make sure that you have removed them all out, not wait for the patient to present back to you again. So but wonderful video. Thank you.
Thank you so much. I think we'll move on to the next video.
Why don't you make a comment, Marian? Your experience on orbital wooden foreign bodies and organic foreign bodies.
Yeah, it's actually very tricky. The presentation, treatment, and the management all are very tricky. So I had patients, we have missed foreign body, later we have taken it when the patient presents with the recurrent fistulas. So that is a very important point. Okay, we'll move to the next video. The saga of a shaky white lens by Dr. Ashwini C from Bangalore. She is working in Narayana Netralaya. Over to Dr. Ashwini, please. Ashwini, can you just unmute yourself?
Good afternoon, everyone. Mr. Navneet, can you please play my video?
Yes, doctor. I'll just play.
One week ago, I could see the sun rising as I was cycling through the paddy fields. One fall that day and I couldn't see with my right eye. I was scared, but my doctor reassured me and I underwent eye operation.
I will now show you how I managed this case of traumatic subluxated cataract. We first did a B-scan and confirmed a normal posterior segment. I will now give you important tips at each step to make complicated surgeries like this simpler. Trypan blue can be used in this case as the fibrinous membrane will prevent it from going posteriorly and help make the rhexis easier. Remember to decompress the bag in case of an intermittent cataracts, as is here, to prevent the rhexis from running off. Use the same nick in the capsule for completing the rhexis and use a micro forceps through a closed chamber, centering it around the lens. Remember to center the rhexis around the lens and not the pupil. Break the synechiae with the iris repositor and peel off the membrane wherever possible. Use the vitrector port such that it is away from the iris as well as the lens edge to prevent a buttonholing and perform a good vitrectomy. An endo-illuminator can facilitate better visualization. A 360 degrees hydrodissection is a must, such that it will allow thorough cleaning of the cortical matter, as is done here with bimanual irrigation and aspiration. The CTR is used to inflate the bag. Implant the CTR after a thorough cortical cleanup to prevent any cortical fibers getting entrapped. Note that the bag opening looks smaller, hence the anterior capsular opening is further enlarged with the microrhexis forceps. A scleral pocket is done at the site of maximum subluxation to fix fix the CTS. Use a Gore-Tex suture which has better longevity and tensile strength. Pass it through the eyelet of the capsular tension segment. Straighten the needle. Pass it through the main tunnel. And feed it into the bent 26 gauge needle which is introduced from the scleral scratch incision nasally. Make sure they form a straight line. Pull the 26 gauge needle to bring the suture out from the scleral incision. Pull the other end of the suture in the similar manner but 1.5 millimeters away. Remember to prevent crossing over of the two ends of the Gore-Tex suture. Secure the segment in the bag along the maximum subluxated edge and ensure that the eyelet is over the anterior excess margin while the segment is within the bag. Pull the suture such that the bag is centered and tie the knot to bury it in the pocket. Gore-Tex suture has minimal biological tissue response and no known biodegradation and has been used for years by our cardiovascular colleagues. You can use glue to seal the conjunctival peritomy as shown. Finally, implant the intraocular lens inside the well-inflated and stabilized capsular bag. Suture the incision if necessary. This is a post-operative appearance showing that the bag is well centered. You do not see the Gore-Tex suture and the IOL is within the bag. This compares the pre-operative and the post-operative where the child has good post-operative vision with insignificant refractive error. Thus, this video highlights how a proper precaution when taken and follow meticulous steps, you can achieve best surgical outcome even in complicated cases.
And now, as I go cycling with my friends again, I can see with both my eyes the beautiful world.
Such a beautiful world.
Thank you, Dr. Ashwini, for the excellent video.
Thank you.
Any comments? Or Dr. Mehul, can you unmute yourself? Can you just unmute yourself, sir?
Yeah. Video with excellent video, and the presentation was great, and the outcome also was very good. But there are many other ways we can do this case. We can use simply CTR ring without suturing, and we can definitely get the better results. To minimize the surgical procedure. And PPC vitrectomy, one opening in the posterior capsule or vitreous axis would have helped to maintain this vision for longer period of time.
We didn't do the PPC because it was a 10-year-old child.
All the more reasons you should be doing PPC then in the case. When it is because I know you can do capsulotomy.
Yeah, later on. So
actually,
sometimes
I think capsulotomy can be done, but vitreous condensation just near the capsule following trauma. I think we have done one RCT and published in IJO comparing no PPC with PPC, even in older people. Been published in IJO. The outcome was better with PPC.
Okay, sir.
Okay, thank you. We have come to the end of the video session. Now we will just move on to the case presentation session. I'm just handing over to Dr. Abhilash, glaucoma consultant of our Giridhar Eye Institute, to take over from me to moderate the case presentations. Over to Dr. Abhilash, please.
Thank you, Marianne. I hope I'm audible.
Yeah,
okay. Without much ado, I think we shall go on to the cases. We had very interesting videos. Now we'll come on to the cases which I hope will be equally interesting. So first we'll have the presentation from Dr. Varsha Bhagyavati. She is from Chennai, and her presentation is titled Enigma of an Avulsed Muscle. Dr. Varsha?
Yes, sir.
here Dr. Abhilash, Dr. Varsha to interrupt, and maybe again panelists can start marking their presentation. They've got a separate link to mark. This is also a competitive one. And just a reminder for the quiz, immediately after this, where the residents who are awaiting, they will be kind of able to enjoy the quiz. The quiz is going to be there. So just bear with us for some more time. Yeah, thank you. Sorry, Dr. Abhilash, to interrupt.
Oh, thank you, sir. Thank you. Welcome.
Yes. Is my screen visible?
Yes.
Sure. Go ahead.
A very good afternoon to all. I'll be talking about the enigma of an avulsed muscle. This 25-year-old gentleman presented to us with severe vertical and horizontal double vision for the past 4 months after a road traffic accident on November 2018. While he was driving a two-wheeler without a helmet, the vehicle had skidded several meters and hit the railing on the side, following which he had lost his consciousness for 10 minutes and had a nasal bleed as well. He underwent a mandible reduction, floor, medial, and lateral wall repair with titanium implant elsewhere. On examination, the best corrected visual acuity was 6/6 in both eyes. There was a gross right hypertropia with increase in the palpebral fissure height, lower lid retraction, and medial canthal scarring. A 3 mm enophthalmos was noted in the right eye. The right hypertropia was 60 prism diopters in primary gaze with 15 diopters of exotropia. There was a gross limitation of movement in depression to -5 and -1 in adduction. The existing post-op CT scan revealed a relatively well-placed floor and medial wall titanium implant. A force suction test was performed and it was positive in depression. Therefore, we took a closer look at the extraocular muscles. There was no obvious entrapment of the inferior rectus muscle onto the implant, and the superior rectus muscle appeared normal. However, the entire integrity of the inferior rectus muscle was not analyzed as the cuts were insufficient. Therefore, we went ahead and did a dynamic MRI. Multi-positioning MR images, 2 mm cuts in primary gaze, up gaze, and down gaze were taken. The inferior rectus muscle was seen avulsed from scleral insertion and retracted into the posterior orbit. The anterior end of the inferior rectus muscle was in line with the globe optic nerve junction. The thickness of the inferior rectus muscle in its contracted and relaxed state was analyzed. As the thickness of the muscle was more in its contracted state, that is, in down gaze, it was suggestive of a functioning inferior rectus muscle with no apparent damage to the nerve and blood supply. Therefore, the diagnosis was an avulsed inferior rectus muscle with secondary superior rectus contracture. We had planned a 2-stage procedure. In the first stage, exploration of the avulsed muscle via an orbital approach was performed. An inferior fornacial transconjunctival incision was made. The scar tissue was released from the titanium implant. The inferior rectus was located in the posterior orbit, and it was gently released from the titanium plate in the floor and reinserted back onto the sclera at 6 mm from the limbus. At 1 month post-operative period, the right hypertropia had improved significantly from 60 prism diopters to 25 prism diopters in primary gaze. However, when the patient had come to us at 2-month follow-up, the right hypertropia was 50 prism diopters. A squint correction was performed by our strabismologist, and per-operatively, the inferior rectus was found to be inserted at 14 mm from the limbus. A superior rectus recession, inferior rectus advancement, and inferior oblique anteriorization was performed. Post-operatively, a residual 5 diopters of right hypertropia was noted. The extraocular movement had improved to -3 in depression. The final outcome was satisfactory with a 3 mm of ENOF in the right eye, which the patient was not cosmetically concerned about. He is planned for the medial canthal scar correction in the future. Muscle avulsion is a rare and grave complication following trauma and surgery. It is indeed a diagnostic and surgical challenge. Dynamic MRI helps not only in localizing the avulsed muscle, but also in assessing its function. Once the diagnosis is confirmed and contracted, The owl's muscle can be retrieved via a standard approach or an orbital approach. In situations wherein the owl's muscle is located in the posterior orbit, an orbital approach is preferable. The success rate in retrieving the owl's muscle ranges from 50 to 100%. A posteriorly transected muscle is difficult to retrieve and sometimes unretrievable. There is 100% success rate documented when an anterior orbital approach is used in the literature. Therefore, a high index of suspicion, good clinico-radiological correlation is essential. A dynamic MRI is a very useful tool in difficult situations. A multi-speciality team effort comprising an orbit surgeon, strabismologist, and radiologist provides success. Thank you for your patient listening. These are my references. I'd like to acknowledge my colleagues and thank you for the wonderful opportunity. Once again.
Thank you, Dr. Varsha. Over to the panelists.
Marian, you want to say anything?
Yeah, this Dr. Varsha, very nice case.
Thank you.
So, how dynamic MRI changes your management?
Ma'am, the one thing is to assess the function. Many times when the patient presents late to us, we do not know the function of the muscle. So probably there could have been a nerve damage as well. So no point going in and suturing it back when we do not know how the function of the muscle is. So in the dynamic MRI, we are able to assess the thickness in the cross section. So though it is avulsed from its insertion, when the patient looks in down gaze, if the nerve supply is intact, the thickness in its contracted state, the thickness in cross-section area increases. So this gives us a clue that there is a function in the muscle and we can attempt the reinsertion of the avulsed muscle. So even in late cases, as in even 6 to 7 years, if the contractile function is there, then it's worth a try. If it is atrophic and there is no contractile function, there's no the necessity to go in and reinserting is not there. And also the location of the muscle can be traced very well by the dynamic MRI.
Okay, thank you. Nice concept. Actually, we are also trying to implement that to teach the radiologist also. It needs some time. Okay, thank you. Nice case.
Thank you very much.
Yeah.
Anything, Ganga, you want to say?
No, thank you. Do you hypothesize this happened during the trauma or during the implant insertion by the orbital surgeon heterogenically, and you're being politically correct?
I'm not really sure if it had occurred before the trauma. What the patient had complained was he did have a hypertropia to start with, and that it did not improve after the surgery. So I think that it would have been present pre-operatively before the primary repair.
That's where the mechanism of injury comes in. And the second question was, when you repair these muscles, you're exploring it, dissecting it away from the titanium implant, the epimysium of the muscle is disrupted. Did you consciously place any barrier to prevent adhesions and dysfunctions of the inferior rectus?
I did not place any barrier, sir. There was scar tissue around it and it was lying on the plate. So I just dissected it gently with the forceps and took it. I did not place a barrier.
Right. The take-home message is any muscle that is damaged the first time, especially the older patients, the longer it takes to repair it, the dysfunction of these muscles, even if they're anatomically correct and the innervation is intact, can be quite devastating. And you may require a strabismus surgery secondarily, provided you ensure that all the scar has been released. And sometimes the scar formation can be a recurrent thing, and we blame it on the implant, and it's not the implant itself, but just the nature of the healing mechanism. And thanks for sharing this wonderful case.
Thank you, sir.
Thank you, sir, for the observations. I think we shall go to the next case. Dr. Kumar KS from Bangalore, and his case is titled Managing a Case of Refractory Post-Trauma Hypotony. Dr. Kumar, over to you.
Morning, rather good afternoon, everybody. Is my screen visible?
Yes.
Yes, sir, your screen is visible. Your voice is a bit low. Screen is visible.
Keep the mic closer to my mouth. Thanks to APOTS and Giridhar Eye Institute for this opportunity. The subject happens to be a 10-year-old boy who presented way back in 2008 with a history of blunt trauma to the left eye with a tennis ball. He was treated for traumatic uveitis and later a transconjunctival cryotherapy for an infranasal dialysis elsewhere. When he presented to us, he was noted to have persistent hypotony with disc edema and hypotonic maculopathy. He was also carrying the reports of an ultrasound UBM, which was done elsewhere, where they couldn't detect any ciliocoroidal detachments or a cyclodialysis cleft in this patient. This is the picture of the UBM. It's not too good, but this is what I have. He was treated with intensive topical steroids, hoping that these will increase the intraocular pressure, although we were acutely aware of the fact that it could also induce a cataract, but the hypotony was the primary concern here. And the patient in between was lost to follow-up, and he was given periocular depot steroids elsewhere. In the next month that he presented to us elsewhere, you can see the lump of triamcinolone acetonide in the upper temporal quadrant in this eye. But that did not produce much change. The intraocular pressure continued to remain low with disc edema and hypotonic maculopathy even as late as April 2008. A repeat UBM was not contributory, and at this time there wasn't any significant anterior segment inflammation either. This is the fundus picture, which shows the presence of fine radial folds around the fovea and the obvious disc edema and mild vascular tortuosity as well. So what to do in this situation was the question. We were at our wits' ends, and as a last throw of the dice, these are some of the options that are available, but what we decided to do was an anterior encerclage with a 240 band. We did try an intraoperative gonioscopy as well after filling the AC with viscoelastic to see if there's any visible cyclodialysis cleft. The steroid lump was excised at this time in the, anticipating that the pressure would raise and this could further precipitate secondary glaucoma. And post-procedure, fortunately for us, the intraocular pressure improved with resolution of the fundus signs, and these are a set of photographs which show the sequential changes in the fundus appearance, both with regards to the optic disc as well as the macula. So post-traumatic hypotony could be related to a cyclodialysis cleft or a ciliocoroidal detachment or a severe uveitis. And the various options that are available in management of this have been highlighted here in red and capital letters. And what we did was the indirect cyclopexy, where we placed an anterior 240 band, and this produces closure of any unseen cyclodialysis cleft by anterior rotation of the ciliary body. This patient admittedly later did develop cataract, and that was also subsequently managed well with cataract surgery. Thank you very much for your patient hearing.
Thank you, sir. Usually UBM as well as gonioscopy, we'll usually see the cyclodialysis clefts, but unfortunately in this case, I think that was not possible.
Kumar, where did you put the 240 band? Behind the muscle? How?
Yeah, right behind the insertion of the muscles. Right behind the insertion.
Usually for
not as in scleral buckle.
Made a tunnel and just tied it.
Yes.
Just one thing, nice presentation, Dr. Kumar. I just want to make an observation and a comment. When we have everything done already and nothing more to do, I think one of the things that we can try is to put iris hooks and do an indented vitrectomy and look for membranes plastered to the ciliary body. Sometimes the ciliary body gets plastered by chronic inflammatory membranes, which causes the low production of aqueous and in turn leading to hypotony, which is sometimes missed even on the UBM. So if you can look for these membranes and try to peel them off surgically, it is known to improve the hypotony. I think that is one thing which we can try in the desperate cases.
Interesting case. I mean, very innovative management anyhow. Because I didn't think of, when you were presenting the case, I was just wondering, I was actually thinking of vitrectomy and injecting probably even silicone oil or something like that to see whether that can really raise the intraocular pressure. But then this is a much more simpler technique, less traumatic. And,
vitrectomy either with or without gas has also been described as an option, But as you rightly said, we try to exhaust the less invasive ones first.
Thank you.
Thank you, sir. I think we'll go on to the next case. Dr. Prashant Pavankule from Nagpur will be presenting a case interestingly titled Knight in Shining Armor. Over to you, sir.
Yeah, thank you. Navneet, can you share the screen or shall I share my screen?
Yeah, I'll share, sir. I'll share.
Okay, thank you.
Yeah.
Mr. Navneet? Yeah.
Can you bring down the volume? Hello. Bring down the volume. Hello. Yeah. This is a volume still low. Volume, I want it low. Please. Yeah. Almost. Can you move back? We begin from the beginning. Yeah. This is a story of a 46 years old carpenter who presented to us with a history of trivial injury at workplace about 6 months back when he was treated medically and he recovered vision as per his records. Since then, he had 3 episodes of pain and redness suggestive of uveitis with progressive loss of vision, which was treated with topical steroids and cycloplegics elsewhere. At presentation, that is 6 months post-injury, his vision was perception of light. Slit lamp examination showed an irregularly shallow AC, 360-degree posterior synechia, complicated cataract with naturally no posterior view of fundus. There was no obvious signs of trauma. B-scan showed vitreous opacities with inferior retinal detachment. Normal chorioretinal thickness. CT scan was non-contributory. So at this point, our diagnosis was complicated cataract with vitreous opacities with partial retinal detachment. Cause was a dilemma. Was it a chronic uveitis or a chronic traumatic endophthalmitis leading to partial RD with a cataract, or was it just an old RD? This was the proposed line of management, and so we started with this. Antechamber entry was done. AC was deepened with viscoelastic, synocular assist being done with the help of an iris spatula. And now the visco is being further injected to create an adequate space in the antechamber. We wanted adequate dilatation of the pupil, so iris hooks were used. And now the capsulorhexis is being attempted. It was a fibrotic anterior capsule, and as you can see, the capsulorhexis was not that easy, but we could attempt it and we could complete it. After that, the hydrodissection was done, followed by phacoaspiration of the soft cataract. Cataract was relatively soft. Patient was young, and as well, it was a traumatic in nature. After that, 23-gauge vitrectomy was initiated. As the posterior capsule was fibrotic, posterior capsulorhexis was done with the help of a vitreous cutter. Vitreous biopsy was done, and after that, completion, PVD is being induced. This is a case of a inferior retinal detachment as well. We prefer to peel ILM in most of these cases of a detached retina. As a case of it being a case of a trauma, we can have a recurrent epiretinal proliferation on the macular surface. So after peeling the ILM over the macular surface, PFCL is being used to flatten the posterior pole, and now we started moving towards the periphery, towards base excision. We could note a temporal, you could see a nasal fold, which was emanating from a fibrotic tissue in the superonasal quadrant. We started dissecting this fibrotic tissue with the aim to reduce the nasal traction, nasal retinal fold, traction on the nasal retinal fold. And slowly, the dissection is being done with the help of a vitreous cutter itself. And slowly, the dissection is very important in this case so that we can relieve that nasal fold. Though a nasal retinal fold not be relieved, but definitely we wanted to do a complete job. And to our surprise, when we were dissecting, suddenly there is a release of a wooden foreign body. We persisted with our dissection of fibrotic tissue so that we do not leave back any residual amount of the broken foreign body. Then the foreign body was picked up with a vitreous forceps, and by handshake technique, it was delivered out through the phaco wound. Again, a tenosum suture was put, and we continued with our further fibrotic dissection to look for any residual foreign body as well as to adequately relieve the traction on the retinal fold. Then after that, fluid gas exchange, PFCL fluid gas exchange was done, retina was flattened, and we could achieve a flattening of the nasal retinal fold as well. Retinopexy was done with the help of an endolaser. And then the case was completed by putting a silicone oil tamponade. So this patient had perception of light at presentation with a complicated cataract, and this is post-op 3 months, best corrected vision 636 with aphakic glasses, and fundus was well attached with silicone oil. So what did we learn? A small wooden foreign bodies are equilucent, radiolucent, and cannot be picked by any investigations like B-scan or CT scan, especially when they are in vicinity of the codes. Suspect a retained intraocular foreign body in cases of chronic uveitis or endophthalmitis whenever there is history of even a trivial trauma. Any fibrotic tissue or encapsulation while doing vitrectomy should be explored for any residual foreign body. Thank you.
Thank you, sir. Panelists can opine.
As a non-real ophthalmologist, can I ask a question?
Please do, sir.
It's nice to watch intraocular surgeries. Hats off to you. You solve the patient's problems. I just noticed that your eyelashes were clipped. So could I find out from you and the others whether still for intraocular surgeries in India, you're all clipping your eyelashes and not draping over your lashes? Could I have some multiple opinions and experts? Thank you.
Yeah. Somehow we do not get a drapes of that good quality which can retain the eyelashes away from the field of view. And most of this drape, the quality of the glue which they use, it gives off the moment it is a wet. And that's why we prefer to do in a cases in vitreous surgery, not in phaco cases.
I have stopped, I don't trim the eyelashes. And sometimes I think 1 or 2 hair comes, but I think draping is very important because I use the non-contact biome. So I make sure that the drape is excellent. So that's why I compliment the nurse or the assistant who does it. I tell them the best part of the surgery is draping, because I think it's very important now for COVID also, so that whatever the patient needs should not come. So I think the best is draping. So I think I'm happy because of the biome from 90. I insist on very good draping and a good sticker. So I make sure that in case there's a gap, I use the extra sticker on the nasal part. But I think the eyelash, my nurse has learned a beautiful technique of so that all the eyelashes are covered.
Yeah, I'm sorry if I'm asking such an irreverent question.
No. I think it's important, Ganga. I think when it's prolonged surgery, I think the cutting eyelash, and then I remember one old lady, and I can't even say old lady, because she said, you cut my eyelash, and she was arguing with me, and I said, what do I do? That time I told her, I am not an oculoplastic, sir.
And you did not have an informed consent for that, right?
The question was anticipated from Dr. Gangadhar, being an aesthetic surgeon.
Sir, Rupesh here. Sir, thanks. And I had a pleasure of working with Dr. Bhavan Kule when he was in Nagpur and assisted intraocular foreign body, and I think that changed the course of my the career to Shankar Netralaya. Thank you, sir. And that was, I think, one such case where we got the intraocular foreign body. I just have very simple question is like when we get some of the surprises, intraop surprises, which probably is not been picked up on imaging or on the examination, how do we counsel such a patient? So we always give them a lot of blanket, a lot of things about that. Let's say suddenly you have to do something inside. and not only in terms of financially, but in terms of extent of surgery and the outcome. And how do we kind of prepare the patient and their relatives? So maybe based on your lot of experience of 20 years plus, how do you say that?
Rupesh, this case was a case of a complicated cataract with posterior vitreous opacity with a detachment. So as I said, we always had a dilemma. Is it trauma related, or it was just a case of a complicated cataract because of secondary to uveitis, or might be a something like a penetrating injury, small prick-like injuries leading to endophthalmitis. So we always had a suspicion something is bad. And so we had taken patient into consent and explained very clearly, we really do not know what we can do. Because the patient started with perception of light. I have shown you the initial photograph.
Yeah.
So fortunately, the patients are mentally prepared because they have been going through the trauma for last 6 months. And in India, fortunately, we are lucky enough where patients do believe doctors still.
We also take a video consent, Rupesh.
Is it really video consent? No?
Now I made it mandatory for all my patients. Okay. All my patients are either trauma only, 4th surgery, 5th surgery. So I take a video consent with the patient and the relative, and they accept that, and then it's in the system.
Dr. Ganga, do you think Singapore is moving towards that? Because we had this dilemma of video consent. I don't think we are anywhere looking towards that.
No, I was part of the patient relations department and a lot of informed consent, which was challenged. The problem with the informed consent process, video taking, is that consent is not a 5-minute process. It sometimes happens over multiple visits. And a lot of formal and informal communication goes on before the patient says yes to your surgery itself. So although we experimented a little bit, sometimes after the paper is signed, the patient walks out through the door, patient just opens the door and asks 2 more questions about the procedure, all of which cannot be recorded in a video consent process. So yes, I think it is good, but I don't think it's going to be a perfect solution. Documentation by writing and in more than one stages, the communication after the patient goes away from home. And most importantly, finally earning the trust of the patient is what is most important.
Yeah, I think Malcolm Gladwell has done a study, and they have quoted a study from US saying that if a physician or a surgeon spends 15 minutes and then he concludes and without that last one statement, and he says the medical legal cases have gone up. If he spends 3 more minutes, that means 18 minutes with the patient, and he says the medical legal cases have come down. I think that the story is not the timing. I think the story is, as Ganga said, gaining the confidence of the patient. Whether I think even if you don't get a signature, it's fine. But I think you have to make sure everything, the record is done. And I think the video consent is also not a protection. I think the idea is to make the patient and the relative aware that we are taking consent, and so that they know that they are agreeing before the surgery. And I also, in the OPD, I tell them, after surgery, if you don't get patient, what will you do? The patient said, what to do, sir? I said, no. For me, I have patients who will argue with me. So I said, why not you tell me what you will do if you are either going to cry or you're going to fight or you want to, or I don't use the word medical legal. I said, what do you want to do? He said, no, I want to do, sir, we'll face. I said, no, that's what we are trying to explain to you, what is going on. I think you have to have I have actually now employed a clinical psychologist during this COVID time for on an online consultation for the patients, particularly trauma patients, and then COVID for testing and all that. So, and I also involved an intern on, this was there in my long time, because I used to call myself a vitreoretinal psychiatrist, because I keep on, I think most of the patients who don't get vision, and I think I have to convince them for a oculoplastic surgery, to get a ocular reconstruction. So I think the process goes on for 6 months or 1 year. And I think the patients believe you, and I think that's important. I don't think they have blind faith. They know that you've done the best. And I remember in the 90s when I used to operate, there are my colleagues who are, you go to Natarajan, we will charge you, but you will not get vision. That's because, I'm happy Giridhar introduced in the beginning. I was the only one to start doing no PL in ocular trauma, and I still do it. And I'm happy with a lot of publications by our Bob Morris and Ferenc Kuhn. But I think informed consent, and I think rightly said, there's no perfect way, but I think we have to make sure you would have a feeling that the patient has understood everything. Because when I operated a no-PL Kashmir patient, and the patient was in the trauma hospital in Delhi for 2 months because of the meningitis, there was a meningeal tear and the CSF leak. And to save the child, the patient was not able to shift it to AIMS for a vitrectomy. When 2 months later they opted, because by the time my name was bigger, so they came to Bombay. I made a big issue. I wrote to Fernando Alvialo. I wrote to Ferenc Spoon. I know that everybody wrote back to me, why are you asking opinion? You are the master. But I said, no, I want an opinion. I kept it. I made a public statement that I'm operating in an OPLI and only in trauma it can be done. And then because we had a government people and finally I got a compliment from Dr. Lane, which is important. So it was a front page article. Because after that the patient got only PL. And I think now she was I think she's past her 10th in Kashmir, and her name is Insha. And I think she was a poster girl where she was written about so much because she had 300 pellets in the face. I don't know what happened, but whatever, she was there with CM, and CM also called me. So I think we have to get particularly trauma. I always have one more line which I don't know whether anybody has in India, because I know the famous case in because of the sympathetic ophthalmia.
Sir, in the interest of time, I think I have to intervene. We'll go ahead with the next case. Thank you. So the last case is Dr. Ashwini. Ashwini is from Bangalore, and her case is titled Clotty Affair. Over to you, Ashwini.
Yeah. Is the presentation visible to all of you?
Sure, Ashwini.
Make it full screen.
Yeah. So, hello everyone. I'll be presenting an interesting case of a 6-year-old child who presented to us with diminution of vision in the right eye since 2 months following a penetrating injury to the eye with a knife. So, on examination, we noted that the best corrected visual acuity in the right eye was 660, and in the left eye it was 6/6. And the pupils were normal in both the eyes. So, on slit lamp evaluation, we noticed that the AC was shallow superiorly. There was a linear corneal tear around 6 mm in length and mature cataract. The slit evaluation showed that the iris was adhered to the undersurface of the tear. The scan in this child was normal. So we went ahead and did a right eye lens aspiration with PPC and PCIOL implantation. This was the plan for the surgery. However, intraoperatively, we noticed that there was an anterior capsular tear just beneath the corneal tear, the part where the iris was adhered to the tear. And after lens aspiration, we noted a fibrovascular plaque on the PC. So multiple attempts to remove this plaque resulted in an intracapsular bleed, and multiple attempts to remove this clot also failed. And assuming that the clot would retract, and as it was not in the visual axis, we went ahead and implanted the IOL. However, primary posterior capsulectomy was deferred in view of active bleeding. 6 weeks post-operatively, we noticed a dense PCO with a frond of vessels, and there was a fresh bleed noted inferiorly, and the vision also had dropped from 618 to 6/48. So in an attempt to shrink the vessels, we went ahead and gave, before performing the membranectomy for the PCO, we went ahead and gave intravitreal Avastin 1.25 milligram. And 3 weeks post-injection, we did not notice any change. Keeping in mind the age of the child, which was 6 years, and the dense PCO, and the drop in the vision and amblyopia in mind, we went ahead and did a pars plana membranectomy and anterior vitrectomy with endophotocoagulation of the vessels. Post-operatively, the best corrected visual acuity was 6/6, and slit lamp examination showed adequate opening in the posterior capsule, and there were no vessels over the PC remnant. And this child maintained a clear visual axis until the last follow-up, which was of more than 3 years. So the presence of fibrovascular downgrowth on the posterior capsule, it's a rare complication of penetrating eye injury, and it's not reported in the pediatric population. Repeated intraocular hemorrhage is a complication of this fibrovascular downgrowth, and this can be managed by endophotocoagulation of the vessels and anti-VEGF injections. Usually, multiple injections are required to shrink these vessels. So the take-home message would be: anticipate the presence of fibrous downgrowth in penetrating eye injuries, and in the presence of a fibrous downgrowth, you should strategize your treatment and expect repeated intraocular bleeds. In the pediatric population, early intervention is needed in order to avoid development of amblyopia. Thank you.
Thank you, Dr. Ashwini.
Dr.
The panelists can have a...
Yeah. And in penetrating injury, the vascular ingrowth is not very uncommon. It's very, very common. And if you do the primary posterior capsulotomy, you can avoid this complication further. And if there is a small hemorrhage, because of it is not a recurrent event, it will automatically will be reabsorbed. That does not require any further management.
So thank you, Dr. Mehul. And more or less the same comment, Dr. Ashwini here. And epithelial downgrowth and fibrous downgrowth are two common events which can happen in pediatric eye injury. So epithelial downgrowth from when you repair the limbal, corneal repair, limbal wound, and fibrous downgrowth from this thing. This is quite common. I had operated probably I don't know how many pediatric traumatic cataract. And if you are not careful enough in removing enough cataract and then those kind of fibrous membranes which are there, during the operation you are going to happen, going to get this thing. And as Dr. Mehul very rightly said, primary posterior capsulectomy or probably removal of as much part of the lens is probably better. And sometimes you, if it is really very bad, you may have to go in for lensectomy, which may be better in terms of outcome rather than preserving some part of the lens capsule. If some of these cases also can go into phthisis also, not particularly this one, but can go into. And I will be kind of bit concerned about injecting intravitreal anti-VEGF, as someone has very rightly said, it is a drug trying to find its indication. So I think before really putting in anti-VEGF in such eyes, I will be probably looking at more data. More randomized controlled trial or anything like that, rather than just based on some anecdotal cases. Thank you.
I think particularly in globe rupture cases, there will be retrocorneal membrane. This will be vascularized initially and later on only fibrous tissue will be there. And that lump you have to remove during surgery.
Yes. Thank you all presenters. We have come to the end of video presentations as well as cases. I thank all the panelists for taking all the efforts to evaluate and be the part of the meeting. Please stay back. You can have a lunch and come back. Now we will start the much awaited quiz competition open to all, mainly PGs and postgraduates and fellows. Meanwhile, we will calculate the marks and the results of videos and the quiz results of videos and the cases will be announced at the end of the quiz. Over to Dr. Rupesh and Dr. Prashop is going to coordinate the quiz. Dr. Rupesh, please.
Yeah. Thank you, Dr. Marian. And I, along with Prashop, will like to welcome you all for the very entertaining and session next 40 minutes. So this will be very timed. This is not going to overshoot because everything is very timed. So let's start this fun. And while you are having lunch, I would like to invite our quiz masters for the day, Dr. Rekha Khandelwal, and this is about Kaun Banega, and those who are non-Hindi participants, so who will be the millionaire kind of thing. So here it is, Kaun Banega is the Hindi term for who will be the person. So without further ado, I'll forward it to the quiz masters who will explain you the rules of the game. Be very clear in listening to what they are going to say, because there are certain rules which you have to strictly follow if you want to really win this competition. And even if you're not winning, how you will be entertained during this next 40 minutes or so, Dr. Rekha will be explaining. So over to you, Dr. Rasmin and Dr. Rekha, and Rajiv is trying to gather some funding for this thing by organizing a research seminar at Shankar Netralaya, where he is organizing a research meeting, how to get funds for some of the projects. So we will probably ask Rajiv after that how to get funding for trauma. Okay, over to you, Dr. Rekha. I'll stop scaring of myself.
So Rupesh, am I audible?
Yeah, maybe slightly less than...
Slightly louder.
Hello everyone. Am I audible?
Yes. Yes.
So friends, we are on the last part of today's session, that is the quiz part. And I welcome you all to this session, which is again organized by Giridhar Eye Institute and SSM Eye Research Foundation, APOTS, OTSI, KOS, and COC. And my sincere thanks to Dr. Giridhar, Dr. Natarajan, Dr. Ganga, Dr. Rupesh for giving me this opportunity to present a quiz with my team members who are Dr. Rajiv Raman, Dr. Rashmin Gandhi, Dr. Rupesh, and Dr. Prashobh Mohan. So we all welcome you all to this session. And it was really an amazing experience working with all my team members for the last 15 days or so. And I'm sure you will all enjoy this part of the quiz. And although it is online, but you won't feel the missing quiz master in between, and we'll try to entertain you. So this is just to tell you again in short that before we begin, there are two separate quiz rooms. One is designed for the residents and fellows, and one is a separate room for non-competitive group. And it is a 35 minutes long quiz, and there are 8 rounds from back to basics to rapid fire. And we have 40 MCQ with only one correct answer. And there are 25 seconds to read the question and answer, and 25 seconds there would be a pause. In this 25 seconds, you will see the explanation. You will also see how you have responded to that MCQ as compared to other colleagues, and what are the scores after each question. Also, you will see the clock running on the top of your screen and how much time is left for the next question to appear. And also you will see who are the top 5 scorers as compared to your own score after each question. So every time you have some target to come up and come in the first 5, and that is how this quiz is very interesting, because it keeps you motivating all the time and keeps you awake and keeps you your adrenaline rush to come up in the next question. So the competitive group or the resident group can come out of the Zoom link for some time till we finish off quiz, but the non-competitive group can be still on the Zoom link. They all will log in their respective codes, because there are 2 quiz rooms with separate codes. So don't interchange codes, or else you will be in the different quiz room. So please enter your code in the quiz room. It's like a ticket cinema hall, और आप जा रहे हैं एक movie देखने और आप दूसरे room में घुस गए तो you will see another movie. So enter the quiz. The quiz is same for both the groups. So the movie is same. We have already shared. Prashobh just show you the quiz rules. So good internet connectivity is very important. In case you lose internet connectivity, don't panic. You can again connect, but you may lose some questions in between. So that is it. So without wasting much time, shall we begin, Rupesh?
Ma'am, can I just share the codes again, once again?
Yeah, madam, just wait and let them be prepared, maybe 2 minutes and all.
Yeah.
I think everyone is very clear about that. The consultants who are having lunch, or they can also log in and share using one of the codes which Dr. Prasad is sending through WhatsApp. And also for the residents, there is a separate WhatsApp group. The codes we have already shared. And for the APOTS member who have logged in, also you can do using the code which is shared with the consultants, the non-competitive category. And if you have any difficulties, please.
The code for the consultants, I just share again. It is 481058. I repeat, 481058. That is for the consultants, and for the PGs and fellows, it has already been shared in the group. 466953. I repeat, 466,953. I hope that is clear.
Yeah. The most important reason of sharing the correct code is that if you are in the consultants, so you probably will not be getting any prize. But if you're in the residents, then you will avail the prize. Therefore, you have to stay. But if you are a consultant and you go to the residence room, and if you win, then you will have to pay penalty. Right, Dr. Asmin?
Yeah, absolutely.
Yeah.
Dr. Rashmin is here.
And Prasok, you put the eye tracker there or not, so that people cannot browse on their mobile? Have you switched on?
Yeah, we have special AI eye tracker which will detect any line.
Right. And then they cannot browse on their Google.
Yeah, absolutely no Google.
No Google.
In fact, the scoring pattern is such that the faster you answer,
yes,
the more you will get. So even if you get a right answer, but if you get it later than everybody else, then it will not amount to much. So that way, I think the system has factored in the spontaneity of the right answer.
This way, the consultants will never win.
Okay, are we ready to go live, Dr. Rekha?
Yes, yes.
Okay.
So how many?
So can you tell how many numbers are logged in into 2 rooms?
What I'm seeing, just checking, the residents are many, over 100.
Oh, wow.
And the consultants.
Just to go on record, we have 120 registered participants in the residence group.
Yes.
And Prasok, where are these residents from? Only Karnataka side or?
They are all over India. They are all over India.
Okay.
All over India. Names from LVP everywhere.
So I'm starting the resident.
Both room you will start simultaneously, right, madam?
I was keeping a gap of 2 minutes between the 2 rooms because
you can keep a gap.
Few people joining on the non-competitive group. Only 5 or 6 I can see to join. Till then we can start the competitive group. Is it?
Yeah, maybe Prasok, you can post it on the Zoom. This one,
yeah,
the link, the code, and this thing for the consultants. We just wait for 2 minutes and then we'll start. The consultants are afraid of competing with residents, right?
They don't want to have a traumatic experience.
See, therefore I have become a quiz master. Then I don't have to compete.
Rupesh, it is true for each one of us. So better not admit it on an online platform. Everyone are hearing it.
Okay.
At least not people from like you, Rashmin. Who are supposed to be the idol for all our postgraduates, they will come to know the truth.
No, sir. We don't want to expose our reality. Okay.
Code is shared, Prasho? Again?
Yes, ma'am. Code has been shared on the Zoom thing also, and I told it orally again. Again, I'll say it. For the consultants, it is 481058.
Yes, right.
These already know it.
Yeah.
Okay, perfect.
So, should we start?
Yeah, let's roll the quiz, ma'am, for this.
So I begin with the competitive group and also this one. Are you able to see my screen, all of you?
Yes, ma'am. Clearly.
Okay.
So here we go.
So the other one has also started. So there are multiple rounds. The first one is back to basics. So 25 seconds.
The The following are the common sites of globe rupture except. Always forget the except wording.
Yes.
Yeah, that's why the tricky thing.
This seems to be a consultant group, I think. There's only two answers.
So I'm not sharing the other group
Okay.
on the Zoom. The other one is going on fine.
So the answer is macula, right? Common sites except. Therefore, I was first confused why macula is the common site. But then when I read except, then it makes sense. Okay, Satish and Nandini are there.
So the second question is for retina people, very common.
So most often quadrant where retinal dialysis will be found after blunt trauma.
Can Dr. Bavankule answer this question or not?
Quick, 4 seconds to go, Prashant.
मैडम मेरी क्यों पोतरी ले रहे हो सबके सामने, बच्चों के सामने मत लो मजा.
All right.
Prashant is the quiz master.
Only 20% got it right. Out of this.
Yeah.
The other rooms got it right, ma'am.
So the other group?
He's not sharing now.
Move to the next question in the other group.
Before the consultants will give otherwise.
Question on the other group, but I'll keep a track now for the next question.
This one is for Dr. Ganga.
There are very less people on this room.
Maybe you can share that other room then.
Okay.
That was about the blowout fracture.
Yeah.
I don't want to put anybody on spot, but
Can you all see now?
yeah.
Much better now. Yes.
Person got it right. Perfect.
This is what getting.
I'll share that group also.
We have a narrow lead here.
Yes, 19, 17, 16, 15.
The fourth question in the first round. Before one more question, and then we move to the round 2.
Yes, so there are 5 questions here.
That is neuro-ophthalmology. Dr. Asmin will not ask you about this thing. You know?
This will also concern Dr. Ganga as well. So
Dr. Ganga also. Yeah.
it's traumatic CCF.
Oh, 80% are right.
I got it right.
Your teaching is very good, Dr. Asmin, looks like. Your eye focus is working very well in India.
Yes. So all 3 nerves can be there, but
Compression of the 6th nerve. This is the reason.
Yeah.
It's right in
Very
the
narrow leads.
there are 4 on 20. 4 people on 20.
Last question of this round.
See, why? This is a very anatomy question. So people need to be aware when they are fixing the leads, right?
Yes.
Dr. Ganga?
Especially.
Important to get basic sciences right.
Let's see what the residents do. They year 1 question. Wow, very nice. Not very good.
Answered mesomic gland orifices.
Gray line matters.
Gray line matters.
Gray life matters.
Very good.
You have to remember that the speed of answering also has marks.
So now coming to the terminology, this is before Annette has rolled out her ophthalmic trauma terminology controversies. So this is
Common language to communicate. We must know all terminologies and speak a
except
common
again.
language.
You put except again, madam, here.
It's an except question.
Yes. You are giving hints.
Yeah, people are still reading the question. Not bad.
Fantastic.
Not bad. Very good. Very good. So the margin is getting
You leader now.
5 people are there. Quite
Yeah.
close.
33, 33, 33. It's very good. What is happening in other room?
Another room. They must be having lunch. Madam, they had a very easy thing morning.
There are many people now. I can
Is
see.
it?
So 5 I can see definitely.
So 5
26, Nandini. Then Satish, Liz, S. So they are on trauma terminology. So one question ahead in resident group.
I don't think any one of this should be asked in the consultant group is how many people use ocular trauma score. Before we ask even this question.
Again, mixed response there.
See, this is where the people will probably, if the bosses are not discussing ocular trauma score, the residents are going to kind of not know about the ocular trauma score, right? Ashok?
Yeah, that's correct.
Yeah, then they should not be managing ocular trauma.
This is the other room.
Okay. You
switched rooms. Okay.
Achha.
Head and ophthalmitis is not a part.
This was one question which I had got wrong many times in my residency. Because instinctively you feel like saying one of these, and actually it is something else. Thankfully, most people have got it right.
Not bad.
Ferenc has made his mark.
Yeah, for quite some time I was thinking Ferenc is in UK, Birmingham. Then later on I realized it was a different one.
Alabama.
Alabama.
Sweet home, Alabama.
Okay, we'll see how it goes. The residents are kicking in. I think they are really enjoying it. And
the lead is constantly changing there. That's a good thing.
Is it?
Annette has joined again. Annette, this is the other group.
Switching to the groups. Okay.
Annette is joining only for the group's answers is no, and then she comes out. Sorry, Annette, to put you on spot.
She knows too much. She probably thinks all your questions are flawed.
The other non-competitive group, 60%. We're correct.
And this is the competitive group, right?
Yes.
A percentage of correct answers.
Now they will feel better, the consultants. I think that's coming into that territory, hopefully.
Anterior segment trauma now.
Yeah.
This is about tetracycline. What's the mechanism of action of tetracycline, so is to say?
You cannot see the full screen, the question. Huh? Yeah.
Not see?
Answer C.
Holding up?
Yeah, now it's better.
Now?
Yes, it's fine. It's fine. Oh, 98% have got it right.
Fantastic.
Some really tight competition going on here.
Who are these people, Prashok? These are all very interesting.
Anirban should be in the consultant group.
Oh.
The other group?
Consultant.
The other group? On the same question.
He wants to become an APOTS member. So
yeah.
That's fair.
I think towards the end of the quiz, we'll remain with the consultants group.
Yeah, you have to give them all. You have to give them all 10 bonus points to keep up.
Yeah.
Okay.
Again, an exact question.
Very tough question. Tough question for the residents. Yeah.
What is the most cost-effective method?
Cost-effective is the most important word.
Yeah.
Actually, that is a clue also, I think.
Yes.
Nirban has fallen behind a little bit.
can still catch up this.
Not bad.
I think I traumatized him.
Good going. This for the residents, it will prepare them for some of the exams also. ICO 1 and 2, right, Dr. Asmin? These are the questions which are asked in those exams.
I see. Clinical.
Clinical.
You have a question on IOS, finally.
So we spoke about the traumatic cataract management, but we never discussed about the IOL. So this is unfair to the residents. We should have taught them in the session now.
Not familiar territory.
Not many people could even complete. Anirban gone completely, huh? From the leaderboard?
No, this is a consultant's group.
Yeah.
This is consultant. Who is Evo?
Evo. Don't do that. 7% I got it.
Interesting.
So Uday has come in now.
Uday is not the consultant, right?
The student group, I think he has taken a lead.
Yeah, Uday has taken the lead.
Because I know Uday from Chennai.
Uday is from SN?
Don't know.
We don't know, ma'am. There is one Uday, of course, in Chennai, but...
Slightly controversial. Do you think?
Bit controversial question.
The only thing I think they want to highlight here is that other three can cause a potential infection, and that's the reason I think they have been excluded by madam.
Okay.
So when you patch the other three, probably it can lead to corneal infection. Yeah, next one.
But we'll go with the standard rule, right? Quiz master remains right at the end of the day.
Yes.
This is consultant group. In between.
Present, the corneal surgeon, the aegis.
So someone is writing on the WhatsApp group, not able to join. Maybe you want to help him.
And I helped them.
Oh, the leaderboard has completely changed here.
Is it?
Anirban is not in top 5 now, and there are new leaders now.
But the leaders are almost neck to neck each other. Huh? I think they are. Is it? Hopefully, it's not fixed.
Job, do you know anyone of them very special? Anyone from...
That brings up our age, because Rasmin and all we have done many years before. That is asking our age, how old. Maybe Pranav will know at least someone.
Posterior to anterior. Except question.
Another except.
But most of them have got it correct.
Anirban has come again now.
Nick, I think, is a nickname.
Nickname for?
It's a nickname, yeah. No pun.
Difficult to say Nikhil or Nikita.
Okay.
This one.
We are on the other group now. Immediately switching.
Yeah, just move it a little bit up so that we can see all the 4 options here.
So Nandini, Evo. I can't see Annette again.
Some number 5 is at 47.
That's a very good nickname for the number 4, S.
S.
Could be anybody.
Yeah. Posterior segment trauma. S must be S Natarajan. I think so. Right? Possible. President reports.
upper, then an accept question.
Again, accept.
Accept is written in capital so that they don't miss.
The moment you see upper, you start clicking because you bonus.
Not bad, huh? People are reading and able to answer so fast. I can't even.
They are on to our trick. Getting the accepts very correct.
Are we halfway down?
No,
18.
18 questions down. The final round is rapid fire. It will get over in a jiffy.
2 minutes, yeah. That will be over in 2 minutes. 10 questions.
And a clinical picture is.
So here, the topper.
Read the question. Yeah.
Question number 19, 90, 88.
And it's an accept in there. We have a half, 50% have got it correct.
Yeah. Actually, we also want them to know the correct 3 things rather than asking ulta, right?
Correct.
Better
That way, accept helps.
2/3 at least they should be knowing correctly.
I think Evo is already maintaining a healthy lead.
93.
Yeah.
Still can be caught up. He or she.
But rapid fire, anything can happen.
Yeah.
And the last question, whoever is doing fast and correct, if there are 2-3 people on the same score, the computer will pick up the one who has answered correctly on the last question and quickly.
That will be the tiebreaker.
That will be the tie.
Is this already including the bonus points? These
Yes,
position?
including bonus.
Bonus is already. I thought bonus will come in the last.
No,
Like typical salary at the end of the year, then you get some bonus performance.
it's already coming in their pocket.
Already coming in their pocket.
This season, madam will say because of COVID, no bonus.
No bonus. As far as they don't cut the salary, then it's okay. Forget about the bonus.
This is a video.
Okay, good. Video is playing very well. Can see. Hopefully, Dr. Bhavan is seeing this video.
Handshake.
Yes, boss.
Yes,
हर
boss.
चीज सुन रहा हूँ रुपेश. Rupesh, Rashmin, you are pulling the guys, younger guys too much, huh? भूलो मत. दोनों के बारे में मैं वो खोल सकता हूँ पुरानी चिट्ठी पट्टी.
Where is this God Navneet? You have to mute non-budget. Can you mute?
So that way, Dr. Ganga also is there.
Yes, sir.
You need to mute someone.
To whom, sir?
No worries.
Okay. Right, sir.
So this is again non-competitive group. There are 5 people with close marks, points. And here,
This to be my question. Hopefully, I can answer this correctly.
pathetic.
We had a very good presentation by Professor Peter Mikulski at WOC meeting on sympathetic ophthalmia recently.
Okay.
Very up to the point.
He will be speaking again at our September 5th, 6th virtual conference.
Perfect, sir.
Ganga's and Rashmin's area now.
Rupesh, do share that sympathetic presentation link here if you have recorded it.
Yes, sir.
We're not allowed to record.
Okay.
But if registered for WOC, you can view it.
Okay.
Or if you're registering for our virtual conference in September, I'm going to invite him to talk about it again because it's a very lovely talk, a different perspective.
Sure. Would love
very
to.
relevant.
Would love to.
Evidence-based.
Evidence.
Are you a member of APORTS here, Dr. Prashant?
Yeah, I am.
So we need to see more of your action in there.
Sure. Rupesh भूल जाता है.
Never. Actually, as a matter of fact, sir was the one person who put it on the WhatsApp group. Is there a uniform consent for trauma? I remember still, sir put it a year ago about a uniform trauma consent, which we have never kind of prepared so far. So that was a very important point, which we need to take it up.
Probably we should, and you can explore that with the college now.
Yeah.
In Singapore, and we can make it a document, but not a very lengthy one.
Yeah, because college came up with standard guidelines for all the other things, procedure, but I don't think I've seen anything of trauma, but we can just try and put it up there. Hopefully we can get something.
No, I've been asking for it since long because this is the gray area. No one has ever created those concepts. If you can create, it would be great help.
Yeah.
Now, the only problem with trauma is consent is that the spectrum of trauma varies very widely.
True, sir.
From simple penetrating injuries to the cornea to open globe injuries, globe ruptures, early presentation versus late presentation. So generic terminologies used in a consent process may not be very relevant. We can use it as a blanket statement. And like Dr. Natarajan mentioned, the time you spend with the patient before, during, and just even before you wheel them into the operating room, where you cannot take a video consent, all of that adds value to the consent process. So, but I think you have to start somewhere.
But something, should we have something in writing as well?
Of course, no, we should.
That part, in spite of spending some hours.
No, we'll take it up, sir. Now, I know I mentioned on that message group also, but we'll take it up surely. And we'll come back to you with some draft and then we'll see how we can take it forward. Yeah. Definitely, we need to do it. Very important.
Meanwhile, Anirban has come back in the lead.
Yeah, halfway through the quiz.
My goodness. He quietly, we just escaped our attention and then he came back. So he needed some attention. I mean,
Dr. Ganga too, yeah. Jinx him.
Move away from him.
I told him no pressure.
Now you're back there watching him, see, he would go down probably.
Here,
I'm really thinking who is S because I saw just Dr. Natarajan changing his costumes there. So I thought he's prepared for this T20.
He just finished his lunch, hopefully.
He finished his lunch.
Yeah.
Yeah, and the sizable lead now.
Looks like very difficult to defeat now, Anirban.
But this top 5 have been the same. And we are already
shuffling the positions among themselves, but more or less they have been the same.
Correct.
No, we have a new person in BL. Or
BL is very interesting again. Manoj was there?
No.
Manoj also is come up, na?
Yeah.
Hopefully it's not Manoj Khatri.
Manoj will be in this room. So I'm searching here. No, here he is not there. In this room.
No, Manoj can go there also.
There also.
Nice, huh? 100%.
100%.
First time consultant all agreed upon a management plan. Nice. No controversy.
Rashmin.
Yeah. Let's see who answers D here.
Yeah.
Oh, 4.1%, because there's no such thing as nucleus of Robinson.
What is this nucleus of Robinson? I'm more interested in knowing that.
Somebody answered here.
4%. 22% people answered.
Let's check that because 22% in the leader, in the consultant group or non-consultant?
Consultant group.
And in the resident group, how many answered that?
4%.
4%, not bad. Those 4 people, Robinson will be their head, their HOD's name, therefore they have to answer that Robinson.
In one of the MCQs, we had asked who invented indirect ophthalmoscope, and one of the option was Appasamy. And
and somebody answered that, right?
Yes.
What I have heard in some of the medical colleges, government, it was kept in. It was kept in the cupboard lock, and then they will say their HOD invented the.
Okay.
So that the aegis suspense remains.
Okay.
One of the favorite question of Dr. Asmin will be, he will keep asking 7 rings, 7 rings. I don't know, I've never seen 7 rings. Voltaire's, it's 7 Voltaire's, right? Voltaire's 7 rings.
Blunt.
So do you do repair, Dr. Bhavan sir, of this kind of cases where you get hypotony?
Yeah, we do try to repair. Means basically, I would have preferred the technique which we shared with Dr. Kumar. Na?
Okay.
Encircling band with a cryo, or going inside and seeing for the ciliary body membranes.
Yes.
Radiology.
This is really happening at a very fast speed. Yeah.
Pause.
Wow.
Real rapid.
But hopefully the question is not long there, right? Okay, very good.
They are just very short.
रुपेश, तुम यार अपने टीचर को पूछ रहे हो सही बोला बनाया कि नहीं?
मेरे तो आप दोनों ही हो।
नागपुर आना है कि
ऐसा कुछ नहीं रहता है।
अभी तो COVID is not allowing me to come. This year I was coming VRSI, then also you kind of.
Yeah, I know. We would be missing you. Yeah. Next year we are having at Nagpur itself.
Yeah, I saw that.
So
yeah.
You will continue to be our guest.
Yeah.
Or Nagpur host party, not a guest.
Not a ghost even.
Yeah.
There are 2 ties now, Uday and Anirban, and Ananya and Manoj Khatri.
7 now. Management.
I hope BL is not Dr. BL Santa, right? Dr. Asmin?
मनोज खत्री का इतना फास्ट नहीं आ सकता यार आंसर, वो अपने जैसे ही स्लो है।
सर्जन तो फास्ट है।
Yeah.
We need to establish some ground truth. Therefore, she's.
No, I would be the first person to object.
No, she's a control group.
Okay.
Non-competitive group. Face control.
Yeah, no, PCR kind of thing, na. So control group, and then rest of the things will follow that.
Back on the leaderboard.
This looks like a nice picture. I don't understand what picture. Gonioscopy. Interesting. Difficult to take images.
भाई रुपेश, लोग तेरे तरफ बहुत ऊपरी नजरों से देखते हैं, ऐसे कमेंट मत कर, यू माइट बी ऑडिबल टू देम। लोग बहुत तेरे को आइडियल समझते हैं, तेरे को रश्मिन को वगैरह। हाँ, हम लोगों ने ऐसा बोल दिया लाइव प्लेटफॉर्म में तो ठीक है।
Hi Rashmin, how are you?
How are you?
Good evening.
Good. So what are you? How is Hyderabad?
Hyderabad is, the cases are rising, sir, now.
So we focus on quiz. Everything in context of quiz. How is quiz conducted in Hyderabad? We ask that. Trauma quiz.
Now we will be on this group only.
So I think we are going to quickly move to rapid fire, right?
Yes. So now we will be on group.
Very good.
How is
Marian is 189.
Yeah.
Marian is 189. Oh, yes.
அது பாருங்க, இது பாருங்க. இல்ல இருக்கு எஃபெக்ட். ஏன் இல்ல? நீங்க அதெல்லாம் ஒண்ணு பண்ணுங்க. நீங்க குடிச்சிருங்க அதெல்லாம்.
Abhilash, don't put it.
அதான் உங்களுக்கு தான் நல்ல பெனிஃபிட்.
Then there's a big gap between first and second.
So you're just about to enter rapid fire, right?
Yes.
There is going to be a breather for them or not? Some drink break? No?
No.
Comfort break?
No.
Poor people. I really feel
Because
Can you just scroll up, ma'am? See the question.
the options are not coming up.
Yes.
Yeah.
Do we get the house abuse, family abuse? Still get that in India also, and places, different places, family abuse kind of cases.
We have not seen.
Oh, good. Fortunate. Okay. The last question.
Video, right?
Yeah, this is video.
The other group also it is playing, ma'am, video.
Madam?
Yes.
Other group also video is playing?
Yes, yes.
Yeah. Dr. Rasmin, if you remember this one in your orientation, someone called it as a black box with waves.
Okay, rapid fire started now.
So let's see how the thing changes. Uday, Anirban, BL, Manoj, and Anjalika. Here. You can tell them, maybe if they are hearing, it's Evo, Satish, Nandini, Mangesh, TAV.
I have an idea who TAV.
Karjani? No.
Thomas Arun.
Thomas Varghese, no?
Yeah.
Yeah.
Okay, it's moving very fast. Evo is still maintaining. Okay, Marian is still maintaining very healthily. Let's move to residents one window. Let's see what's happening at the residents level.
There's Anirban and Uday.
Let's see what is happening there.
Anirban in the lead now, narrow lead.
Everyone has maintained a healthy lead. Manoj Khatri is catching up. There is no negative marking. Huh? We should have probably given negative marking there. Anirban would have gone down.
Now we are switching to only one group, right?
Yeah, just keep it there, residents. Anirban is still maintaining a good lead. Oh, there's.
Oh, wow.
See, last step.
Yes.
Nail biting competition.
Yeah.
Photo finish.
Amazing. And other two are locked at 196, 196. See?
Yeah. It depends on how desperately they want the airport's membership.
Who wants a airport membership?
Yeah, Anirban and Manoj.
Yeah. You are done.
Come to the final question here.
PL has suddenly come up. Manoj Khatri has gone down. So many places going on.
Answer to the group is almost decided now. Avo has taken unassailable.
Huh? Oh, wow. Finally.
Yay.
Oh, Anjalika.
Completed that.
Dr. Gangadhar, well done.
Saying yay for my specialty.
Huh?
Fantastic.
So Anirban is the first. Then you got the resident. Who is the second one?
Uday and BI.
BI or BL? What is it?
BI, I think.
Okay. Don't know.
Can we verify the names? Yeah.
Can you just identify yourself on the WhatsApp group?
Okay.
Uday and BI.
They may have gone out of the Zoom, I think.
Just ask them to log in on the Zoom again.
I've messaged on the group.
Yeah, you can say all of them can log in the Zoom again.
Yeah. You have to identify themselves first. Yeah.
Yep. Nick also came in the...
Giridhar Datta has identified himself. He's a cornea fellow at LV Prasad Eye Institute, Bhubaneswar. Congratulations.
All right, wonderful.
Oh, Anirban, I know. Okay, right. Yeah, he's a quizzer.
He's
a quizzer. Yeah.
Oh, so he was playing nicely.
Yep.
Okay, so 1 minute, I will share the certificate for Anirban. And where is the share screen button gone? Okay, I cannot share the screen. Okay, no worries. You continue.
Nick has to stop sharing.
No, it's okay.
And Uday is Uday Tekchandani.
Uday?
Senior resident at PGI Chandigarh.
Yeah, yes.
Uday Tekchandani, yeah?
Yeah.
Yes.
But he's also a quizzer.
And Anirban full name is what?
Anirban Datta.
Okay.
And BL is Blanche Lim from NUHS.
Yeah.
Wow, sir.
For the details. NUHS.
Yes. What is he? Blanche
Lim.
Now I know Anirban syndrome.
Okay, can you spell it out for me? Branch?
BLANCHE.
BLANCHE.
Then
LIM. LIM.
Okay. Good. I am ready with my certificates. Whenever they start, I can share the certificates.
I just shared the Zoom link so that they can join in.
Yeah.
Navneet, can you just send me the Zoom link again? I'm just finding it difficult to find it.
Sir, shall I put it in the WhatsApp group?
Yeah. No, put it in the WhatsApp group. Yes.
Yeah, I'll put it.
Well played, Marian.
Yeah, thank you.
So after this, we announce the other results. Hello, Rashmi. How are you?
Hi, sir. Good afternoon.
Nice to see you.
Hi, Rashmi. Sai here.
Hi, Sai. I didn't know you sang so well.
Marian, are we ready with the other results?
Yeah.
Can we announce?
This is quiz.
Let quiz be over.
Yeah.
2 minutes after that.
Yeah, Dr. Prashov, I have put it in the WhatsApp group.
Dr. Rekha, just a doubt. Senior residents are included?
I think, right?
Yeah. Senior residents are included.
Yeah.
Okay.
Can you just read the names again, the winners of the quiz?
It's Giridhar Datta, cornea fellow at LV Prasad Eye Institute, Bhubaneswar. Uday Tekchandani, senior resident at PGI Chandigarh, came second. And third place goes to Blanche Lim from NUHS. NUHS, anybody knows the expansion? Sir, Rashmi, sir?
Doctor.
Singapore.
Yes,
Singapore.
National University of Health, Singapore.
National University Health System or National University Hospital.
Fantastic. Well played, and Anirban.
They are an international winner also.
I really show the reports kind of a strength.
Hello?
Yeah. Am I ready to share my screen?
How many have the participants joined?
They are here. They are all there, sir.
Okay, they are all joined. Nirvan has joined, yeah.
I can see Mr. Deep Chand Saini, Anirban Datta, and
Uday Tekchandani, yeah. Uday Tekchandani, Anirban Datta, and Blanche Lim. These are
yes.
Okay. Thank you. First of all, Dr. Rekha and Dr. Rasmin, so all the team for really conducting this quiz very well. And thanks for everyone to participate. And I think it was a very healthy participation.
Can the other participants please mute themselves?
Maybe ask.
I am muted, sir. I am muted. Yeah.
Okay, great. So, okay, it was a very tough competition, and we can see how the pendulum was swinging from one member to another member. But finally, we have top 3 winners, and then the certificate is also ready for them. The first one is Anirban Datta. And can you come online and just introduce quickly about yourself?
Good afternoon, sir. I am Anirban. I am a cornea fellow at LV Prasad Eye Institute, Bhubaneswar.
Okay. And where have you done your MS from?
I completed my DNB from Arvind Eye Care System, Tamil Nadu, sir.
Okay, fantastic. So congratulations. Dr. Natarajan, if you want to say.
Welcome to awards and hearty congratulations.
Thank you so much, sir. Ama sir, kunja theriyum.
Dr. Ganga, any word for Dr. Anirban?
No, he spoke Tamil words, so he's automatically included in airports now.
Sir.
Dr. Giridhar?
Congratulations.
Yes, thank you. Okay, good. So we'll move to the second winner. Sorry, there is something. Yeah. So I will just change that. We congratulate Dr. Lim from Singapore. Dr. Lim, are you there?
He spoke Tamil words, so he's on.
You have to speak Tamil words now if you want to be a member of awards. So we have not disclosed this. So if you are working with Dr. Ganga, you would have learned some words.
Hello, thank you very much. It was a very fun quiz.
So we'll move to the second winner. Sorry. No, I will coming to do that. Dr. Blanche is the second winner. We'll come to the second winner also.
Welcome, Blanche. Where are you working now?
I'm working with Dr. Ganga in NUHS.
Okay. I have to speak Tamil words now. If you want to
I will defer to Dr. Ganga then.
I would have learned some words. Okay, thank you.
Blanche Lim was third place.
Hello.
Can you mute everyone? Second winner, we'll come to the second winner also.
Navneet, please mute the others. Yeah, doing sir. Muting. Yeah.
Okay. So we have the second winner in the resident category, Dr. Uday Tekchandani. Uday, will you like to say something about yourself? Congratulations.
Thank you. Thank you so much, Dr. Rupesh. Good afternoon. I'm Dr. Uday Tekchandani, originally from Bombay. I have done my MS from PGI Chandigarh and currently a senior resident in PGI Chandigarh itself. And my department is vitreoretina, oculoplastics, and ocular oncology.
Wonderful. So you did. How you answered the terminology question correctly? Because you said Bombay or Mumbai. It should be Bombay or Mumbai.
Mumbai.
Yeah. So I want to see whether you answered that terminology question correct or not. Correct.
So where are you from Mumbai? Which part of Mumbai?
So Bandra.
Okay.
Yes, sir. You answered correctly.
You answered correctly, huh? Okay.
Congratulations, Uday.
Thank you, sir. Thank you so much.
Sir, a very interesting field. He want to impress both of you. He's a retina as well as oculoplasty.
Yeah.
Two top persons of oculoplasty.
One word of Tamil.
Sorry, sir. I have no idea about Tamil.
Okay.
Hello.
Navneet, you can mute Dr.
Hello.
Hello.
Muting.
Navneet, can you?
Okay.
Quiz prizes.
Yeah.
Thank you, Dr. Uday. We are highly impressed with your quiz.
Yes, sir.
Another award video and everything.
Yeah. I think Dr. Rupesh, you are done with the quiz prizes.
Yes. So that's what let me just
Yeah.
switch off for the where is it gone?
Stop sharing, sir, please.
Yeah. Thank you very much for the opportunity and really a pleasure. Thank you.
Okay, I really thank all the quiz masters and the contestants for such a wonderful quiz. Now I think we will move to the most important part of the webinar. Dr. Sai Kumar, President of Cochin Ophthalmic Club as well as Medical Superintendent of Giridhar Eye Institute will announce the results of video as well as the case presentation. Over to Dr. Sai, please.
Good afternoon, ladies and gentlemen. It was a wonderful CME program and enjoyed every part of it. The quiz was fantastic. So it's my pleasant duty to announce the results of the video as well as the free paper competition. The first place in the video goes to Dr. Nandini. And the second place in the video goes to Dr. Alpesh. So these are the two persons who have won the video competition. And from the case presentation, the best case goes to Dr. K.S. Kumar. So Dr. K.S. Kumar has won the best case, and Dr. Nandini and Alpesh have won the best video. Congratulations to all of them. I think, Marian, you can announce the prizes.
Yeah. Dr. Nandini, can you just introduce yourself?
Hello. Yes, ma'am. Yes, ma'am. Sure.
Hello.
Yeah, I'm audible.
Yes, ma'am.
Am I audible?
Yes.
Yeah. Myself, Dr. Nandini. I am from Narayan Netralaya. I did my fellowship in Narayan Netralaya in 2015 with Dr. Himanshu, and I have joined here with him only as junior consultant. I am more involved in cornea imaging and about the stem cell research work. And most of our Pentacam data, whatever the recent thing which is happening, I'm more involved in that. And you will be seeing our publications. Thank you so much.
Dr. Alpesh, just 1 second. Can you just introduce?
Thank you very much for selecting my video.
Unmute yourself, please.
Hello.
Hello.
Yeah, you are audible.
Hello. I did my MS from the MNJ Institute, Ahmedabad, and then did the fellowship of the retina with the Dr. Giridhar sir at the GEI Cochin. And I was there for the medical retina with the Murlidhar sir also. Hello.
Dr. K.S. Kumar is here. Can you just...
Hello.
I think it's not there. So the first prize in the video is a cash prize of ₹10,000 rupees, and the second prize in the video is a cash prize of ₹5,000. For the case presentation, the best case will receive a cash prize of ₹5,000. Now we will move to the last part of the session. Dr. Gangadhar Sundar, Chairman Scientific Committee of iPods, would like to speak a few words to us. Over to Dr. Ganga, please.
Thank you, Marian, and thank you, Dr. Giridhar, and thank you for everybody for joining us today. I just want to make an observation that India has a population of 1.3 billion, and that's about 18% of the world population. And the Ocular Trauma Society of India has actually done wonderful work. Hello? I just encourage every single...
Hello? Can we try to mute everyone?
Yes, sir. Doing.
I strongly encourage every ophthalmologist in India to join the Ocular Trauma Society of India by default. Number one, they should automatically become members, like how you become members of AIOS, because all of you manage trauma. And by default, being one of the largest subgroups of the Asia Pacific region, invite you to join the Asia Pacific, because not only do you have high quality teachers in India, high quality institutions in India, you do high quality work, and we want you to come out to the world and share your good work and share the knowledge, so we flatten the world. So I take this opportunity to invite you to join Asia Pacific Ophthalmic Trauma Society number one. Thank Dr. Giridhar for organizing the third APOTS webinar along with the Giridhar Eye Institute, and then invite you to the fourth APOTS webinar, which is going to be held on the 15th of August. We'll send it out to you all through emails very shortly. And the fifth APOTS virtual conference, which is going to be done in September 4th and 5th in lieu of the Bali meeting. So thank you for organizing such a wonderful meeting, and I invite you all to seeing you again in the near future with more active contributions. Thank you, Maria.
So on behalf of Airports, thanks to Ganga and Rupesh and our entire Airports team, plus thanks to Giridhar and Ophthalmic Trauma Society of India. Thank you very much.
On behalf of Ocular Trauma Society of India, I would like to thank Dr. Giridhar and Airports team for organizing such a wonderful webinar and active participation of all participants and all speakers. Thank you very much.
Hello.
Now we'll move to the concluding remarks. Thank you all. Dr. Sai Kumar. Yeah. Over to Dr. Sai.
It's a very, very pleasant duty to thank all the participants, the organizers. Marian, I think, deserves a special word of thanks, because she has put in a lot of hard work in the organization of this meeting. And Dr. Giridhar, as always, has taken a lot of special ideas there. This particular CME, he was involved right from the beginning. A lot of ideas as to how to, include various people. We kept on changing the program, including more and more faculty. It is a pity that we could not do the 2-day complete thing that we planned in April. But definitely, I think we have made amends by doing a good webinar today. So thank you to all the participants. I also thank all the participants on YouTube and Facebook Live who will be watching this program and all the speakers who have spoken here.
Hello.
Thank you all. All the video presenters and the case presenters will get an e-certificate also within 1 or 2 days.
Okay, Marian, we can remind them of the feedback also. Maybe just a separate feedback.
Yeah. Okay.
Thank you. Thanks a lot. Bye.
I'm sharing a link.
Yeah.
Dr. Rekha, would you like to inform the audience about the winners among the consultants?
Yes.
No prizes, but just for curiosity.
Yeah.
So what are the losers they are supposed to do? They are supposed to do the revalidation course. Sorry, therefore I am not participated. Go ahead, Dr. Rekha.
1 second. So I'm sharing.
You can just announce, ma'am.
Yes.
Little louder.
Could you figure out who is above?
So AVO is with 240 points. AVO, I could not figure out. Rishabh?
I do not know. They have to identify themselves if they're listening. Who is AVO?
Second is Satish with 217 points. And third is Nandini with 204 points.
Congrats to
Okay,
all.
thank you all.
And
I think
I've shared a link on the resident group to fill up a short question feedback form. So we will get the feedback and I'll share with you all.
okay.
Thank you, madam.
Thank you once again all. Okay.
Thank you very much. Thank you.
So thank you. It was fun.
Thank you, Dr. Natarajan. Thank you, Rupesh.
Thank you, Dr. Gangadhar, Dr. Rupesh. Thank you.
Thank you, everyone. Bye-bye.
Bye.
Special thanks to you.
Thanks to you all, sir.
Yes.
Thank you, Marian madam.
Thank you all.
I would like to thank a big word to Microvision for helping from the background, all the technical work, flyers, everything. Great help.
Yeah.
Great thanks to Mr. Navneet, Mr. Sinikumar, and all the whole technical team. Thank you once again.
Thank you, sir.
Ashok is there.
Thank you, doctor.
Ashok, you are there?
Sir, yeah, he left just now, sir, actually.
Okay, now.
Yeah. He was just attending other meeting. Yeah. Right, sir.
Thanks,
Thank you, sir.